I feel like we've been getting like 10 to 11 people for the most part.
10 to 11? Okay, we're basically there. Um, okay, yeah. So why don't we get started? Because I think this is going to be a long session. So I think I've met most of you. If I haven't, my name is Pelkey. I'm one of the PGY6s here at Mac. I'm going to be doing the cardiology section. The cardiology section tends to be reasonably a heavy focus of the IM Royal College, just because you do come across a lot of cardiology topics. So it's probably not going to be entirely comprehensive, but it is meant to at least be a resource that you guys can come back to review when you guys are studying. So, I'm going to try to make this as painless as possible. There's a lot of topics to cover. We're going to just kind of start off with like the more high yield things and then get into some of the stuff that doesn't appear that much on the exams. And then we'll try to take a quick break in the middle and then we'll leave questions at the end if that's good. But feel free to sort of jump in during the talk if you do have questions. So I just need the slides. Okay, perfect. So I completed the Royal College exam a few years ago. It was 2 years ago. As I said, we won't be covering everything. These are kind of updated slides from the years past. This session has been very helpful. I remember when I was studying for the Royal College, and so it's very similar, but there have been some new guidelines in the interim, which this will include. Okay, so we'll just get right into it. These are just the internal medicine core competencies that you're expected to know from the cardiology section. And so I'll just leave that there for your reference. So now when it comes to guidelines, there's a ton of guidelines that you could potentially look at. I don't think it's worth looking through all of them. I've kind of highlighted in red the higher yield ones. But as we go through the talk, I'll talk about the ones that I think you should probably read or at least look at their figures. But you certainly don't need to read these in full. The two big updates that have come out since sort of the last few years, that's probably going to be slightly different from the Royal College that I wrote, is that there was a new antiplatelet guideline that came out in 2023. So that is kind of important for you guys to know because you are often the first line people dealing with the ACSs. And then there's a new sort of CCS driving restrictions guideline that came out in 2023. So those are probably worth looking at if you have older material, just updating those. As you go through guidelines, I would say prioritize all the Canadian guidelines. So the CCS is pretty comprehensive. They have a lot of topics that they cover. If there is something that's not available when you guys are studying in the CCS guidelines, then you should usually go to the American guidelines, the AHA. And then, as a last resort, if it's not available in the Canadian or American guidelines, look at the ESC. For example, the pericarditis guidelines are best outlined in the European guidelines compared to the Canadian and American. So there's very few things that you'll need to go to the American guidelines for. Okay, we talked about that. So we're going to jump right in. We're going to start with acute coronary syndromes. And we'll start by talking about the sort of definition of it. You guys probably hear people talking about the universal definition of MI. It was kind of redefined a few years ago. And when we were talking about really like a type 1 MI, those are our true ACS sort of events. And then these are sort of type 2 are like supply demand mismatch type events. And then the rest, I think it's worth just knowing the nomenclature, but I don't think you'll be asked about this in great detail. But just good to know that this kind of definition exists. The most important sort of type of MIs we're going to be talking about is the type 1 MI, which basically is the concept of the formation of an occlusive thrombus secondary to a plaque rupture. And so when you want to diagnose a type 1 MI, as you guys know, because you deal with this all the time on your call shifts, you really want some sort of supportive information to show that there's been some degree of ischemia. There's been evidence of, loss of myocardium, whether that's through an angiogram, or the steps before that, which include, ECG changes if you have ST elevations, Q waves even, and then nuclear studies that may show a wall motion abnormality or echoes that show wall motion abnormality. So that's kind of the type 1 definition. Type 2, as you guys all know, is kind of what we talk about in the supply demand mismatch. And usually these are pretty clear. And so the questions you'd probably get that trigger you to think, is this a type 1 or type 2, will be, someone presenting with chest pain, and then they tell you their hemoglobin is 50, right? And so those types of pieces of information are there to trigger you to think that there's some either decreased supply of oxygen or increased demand for whatever reason. And so I won't dwell on that too much, but this is kind of the definition where you do want to see some rise in your biomarkers, plus evidence of ischemia, some objective evidence of ischemia. Sorry, my computer's being a bit laggy here. There we go. And so this is just like I've put a lot of tables there just for you to reference. I find it's a bit easier when you have flow charts. And so I'll skip over some slides, but this is just so that you have these things in your slide deck. Now let's talk about STEMIs first. And I know everyone probably knows this, but it's always important to review this criteria because it's useful to have this information right at the tip of your tongue for your oral exam, for example. If someone asks you, how do you, have a ECG diagnosis of a STEMI? And so it's important to know that, you need at least 1 millimeter of new ST elevations in contiguous leads outside of V2 and V3. And just because of the positioning of the leads on the chest, the criteria for V2 and V3 are slightly different. There's a higher threshold to be able to call ST elevations in V2, V3, and they're kind of age and sex dependent. And so greater than 1 millimeter, any lead, if we're looking at leads V2 and V3, we're in men, if you're over the age of 40, you want greater than 2 millimeters. And if you're less than the age of 40, you want greater than 2.5 millimeters. And that's because, as you know, when you look at the ECGs of young people, they often have early sort of repolarization abnormalities that can be within sort of normal physiologic limits. And so the threshold in young men is slightly higher, so you need at least 2.5. And then for women, it's greater than 1.5, regardless of your age. Now, it's important to remember that, if you see ST elevations and they're like just below your cutoff, it's not like you say, oh, this is definitely not an ACS. You have to remember that ECGs evolve over time. And so if you're given an ECG that's kind of borderline, you do want to sort of repeat it every 15 to 20 minutes and see if those things evolve. So these are guidelines in terms of STEMI criteria. But as you know, in practice, there is some gray areas around that diagnosis. As you know, it requires urgent recognition and management. And in terms of your management options, there's really you have to revascularize these people, otherwise their mortality is very high. Then you have to decide on how you're going to revascularize them. And so the two options are usually primary PCI or thrombolysis. Very helpful to know if you don't know how to be able to localize your territories when you look at an ECG, right? So you have your sort of septal leads, V1, V2, then you have your anterior, lateral. Remember that 1 and AVL are your high lateral leads, and these are your inferior leads. And it's useful to know the territories as well. I don't think you'll be asked in detail, but it helps in an oral scenario to have some suspicion of something is an inferior infarct involving the RCA, for example, and if you'd require more attention to conduction abnormalities, for example. So that's what I will say about that. So talking about STEMI management, and we'll spend a lot of the talk about today about ACS and STEMI management. And again, a lot of it is probably a review of what you already know, but remember that The four sort of things you want to be able to say right away is you want to, check hemodynamic stability, of course. And then you want to use supplemental oxygen only if people are hypoxic. So we do have studies that show that if you are not hypoxic, supplemental oxygen actually had a signal towards harm and increased mortality. And so you're only using it if the patient's hypoxic. You can use nitro spray. As you know, you want to avoid it if you have an inferior STEMI, because that could mean that your RV is involved, and your RV is a highly preload dependent structure. And then you are okay to use things like morphine for ongoing pain, but you do want to use it judiciously, as to not alter the patient's sort of mental status and hemodynamics. Aspirin, we always use aspirin. There's very few circumstances where you wouldn't be safe loading someone with aspirin up front. So that's 160 milligrams PO chewed. Usually, we're going to talk in detail about the second antiplatelet, but also usually quite safe to say you're going to load someone with a second antiplatelet. Now, there's some nuances about which second antiplatelet to use. Now, your options, your second antiplatelet is always going to be a P2Y12 inhibitor. And there's three options we have here. In Canada, we use Tycag and clopidogrel more. Prasugrel is also available, but just not used very much in practice yet in Canada. But you do want to use one of these three. You load at these doses. The exception to that is the load for clopidogrel if you were to thrombolyse that patient. And so that is age dependent. And I think it is, even if you don't remember the exact doses, I think it's important to just know that there would be a different dose depending on the age. And I think if you say that, you've demonstrated that you sort of know that there's a nuance to this. And so if you are less than 75 years old, you're going to be giving them a full 300 milligram load. But if you're greater than 75 years old, if your patient is greater than 75, you'll only be giving them a regular 75 milligram dose. Okay. And then as per the most recent antiplatelet guidelines that we'll talk about a little bit more, if there is a very high suspicion for surgical disease, so that means often it's poorly controlled diabetic people, or people that have sort of imaging before that suggests that they have multivessel disease, it is reasonable to delay that second antiplatelet, only because, as you know, the load of a second antiplatelet would delay someone's ability to go for CABG if it's required urgently in an ACS circumstance. So that is reasonable. Anticoagulation wise, we know that improves survival. Typically, we would use IV heparin or low molecular weight heparin. And fondaparinux, I know we use it often, very frequently at our site. But it's actually not recommended to be used if someone is actually going for primary PCI, which is most of our STEMIs, just because there is a signal towards increased risk of catheter-associated thrombosis. So just remember, that's like a little bit different than what we do in practice here. But you're always going to be safe to say, IV heparin upfront. And then in terms of reperfusion, this is the most important thing that improves survival. And so at our site, since we have PCI capabilities, we usually see primary PCI. I know we don't have that much experience here with thrombolysis, but it is still something that happens. So it's worth reading about that just a little bit, because you could be given sort of questions about being in the community where you're not at a PCI capable center. And so we'll talk a little bit about thrombolysis. And then rescue PCI is basically sending someone to the cath lab after they've been lysed and failed lysis. So those are sort of our mainstay principles of STEMI management. This next table is important to know some of these timings. And so this is talking about what to do if someone comes to hospital with a STEMI in terms of determining what their reperfusion strategy is going to be. The very first question you need to ask yourself is, am I at a PCI capable center? If you're at a PCI capable center, and that's the first question you want to ask, then the answer is easy. You need to get them to the cath lab as soon as you can. And it's ideally, in terms of timings, it's ideally within the first 90 minutes after first medical contact. So that's what FMC stands for on these slides, first medical contact. Okay. So they show up, they're able to get a PCI like they show up at the general. They have to get stented ideally within those 90 minutes. Now, when things get tricky is if you show up at a non-PCI capable center. At that point, you then have to ask the question, um, am I able to get there, get the patient at a PCI capable center within 120 minutes from first medical contact? If so, then you transfer them. Ideally, you'd want that transfer time to be less than 60 minutes. I don't think it's super important for you to remember the 60. I think it is useful to remember the 120 and say, if I can get them to a PCI center within 120 minutes, then I will, transfer them to a PCI center for primary PCI. If we're going down this sort of pathway, I hope you can see my mouse. But if you are going down this pathway, where you can't get to someone to a PCI capable center within 120 minutes, then you have to make the decision to lyse. And so if you are going to lyse someone, you need to do so within 30 minutes. Okay, so that decision needs to be made fairly quickly. You want to lyse them within 30 minutes, and then routinely, these patients should get transferred to a PCI capable center. This is kind of like what we call the pharmaco-invasive strategy or the drip and ship strategy, where you lyse them and then you send them over to a PCI center where they're going to eventually need an angiogram. The urgency of that angiogram depends on how they've sort of responded to lysis. So if lysis is successful, then you can wait up to sort of 24 hours. Before sending them to the cath lab. But if it's unsuccessful, and we'll talk about what that looks like, then those people should get sent urgently to go for urgent revascularization at a PCI capable center. Okay. Okay. So in terms of deciding our reperfusion strategy, the most important question, there's a lot of important questions you want to ask these patients, but one of the most important questions is when did their chest pain start? We do know that patients that benefit from lysis are those who had symptom onset within the last 12 hours. So if you have a patient that's presented to you that, has been having chest pain for 12 or more hours, you look at their ECG, there's already Q waves there. You can even POCUS them, and they have wall motion abnormalities that are clear. Those are the people you want to be very careful about in terms of making a decision to lyse them. And that's because we know that the risk of bleeding, the risk of mechanical complications, certainly outweighs the benefits if someone is presenting with a late ACS event. And so onset of chest pain is very important to know. Now, for primary PCI in practice, most people with a STEMI presentation will go for PCI. The exception to that is if they're very, very late presenting. But the actual sort of clear benefit of PCI, even after 24 hours, is a little bit uncertain. It is still something that is probably routinely done, even from a diagnostic perspective. But that's just something important to keep in mind is when you're presented with a patient, make sure you ask that question first, so you don't lyse someone that's actually presenting with a late presenting STEMI. Okay, so fibrinolysis, I do remember this being something you need to know. And it is similar, and if not the exact same as the contraindications for TPA in the stroke patients. And so it's, I don't think you'd need to list off all of these, but it is important to recognize what major absolute contraindications would be and when you would be nervous and sort of the relative contraindications as well. But I think these are pretty self-explanatory, so I won't read them off. And then I've put up your TNK dosing up in the top corner for you to look at. I wouldn't waste too much time trying to memorize the T and K dosing. All right. So now moving on to NSTEMIs, the principles of management are very, very similar. Pain control with nitrates, oxygen if needed. You always aspirin load them. The second antiplatelet um, is usually recommended as well. The caveat to that being if you think that they're going to go for a coronary angiogram, and this was in the most recent sort of antiplatelet guidelines. You can see it in red at the bottom here. So if you think that patient's going to be able to go for an angiogram within 24 hours, you don't have to load them with a second antiplatelet. If you think the angiogram is going to happen more than 24 hours after their presentation, then you should load them with the second antiplatelet. Sometimes that's hard to predict, but those are kind of just general guidelines. That's not a sort of hard and fast cutoff. And then anticoagulation wise, here you can really use any of these anticoagulation strategies. Okay, so when someone presents with an NSTEMI, the vast majority of patients really benefit from upfront intervention, whether that's immediate, so right at the time of presentation, or if it's sort of within 24 to 48 hours, kind of depends on how the patient presents. It's useful to know what features of an NSTEMI presentation would cause you to want to cat someone immediately and almost treat them like more of a STEMI than an NSTEMI and talk to the interventionalist early. And so what we include in that is things like refractory ischemic symptoms. So that's someone who, you've tried nitroglycerin on, you've tried beta blockers, calcium channel blockers, whatever it may be, and morphine, and they're still having pain. That's a really high risk feature, and those people should go for angiogram early. Hemodynamic instability, of course, cardiogenic shock, mechanical complications, any arrhythmia, so whether that's heart block or even VT, those people should go right away. And then, of course, if they have ongoing dynamic changes. You can use your risk stratification scores like GRACE, the GRACE score, which I've put on the next slide. I don't think it's worth sort of memorizing all the features of it. It's kind of self-explanatory, though, in terms of the features that would make an ACS presentation high risk. And then, KILLIP class is also part of that, but I don't think you need to memorize that. I think the general principles is that you want to assess to see if the patient is high risk to determine if they're going to need to go for revascularization early or not. Okay. So this is the GRACE score if you haven't seen it before. So the components are, age, heart rate, your systolic blood pressure, your creatinine. If you've had a cardiac arrest, if you've had a cardiac arrest, then obviously there's no question about it. You should be going to the cath lab. And then your tropes and your KILLIP class. So that's one of the sort of tools that you can use. And even like, in an oral scenario, you can even just say like, I would calculate the GRACE score just to show that that this is how we can re-stratify people. Okay, so now you have your patient that's, you've identified as high risk, you've sent them to the cath lab, and now you're going to think about your adapt duration. Um, this is where there's been some changes with the antiplatelet guidelines, but it's not overly complicated. The first question that you want to ask is this a um, sort of ACS or is it an elective PCI? So any of the ACS people, really, you're going to keep them on DAPT for 1 year. It's the elective PCIs that now are sort of showing a signal that it is safe to only keep them on DAPT for about 6 months. But there are angiographic and bleeding risk factors that will factor into whether or not someone is going to have sort of a abridged or elongated course of DAPT. This is from the CCS antiplatelet guidelines. Don't memorize this. I just want you to understand the sort of concept behind this. So these are what we consider complex PCI features. And that means that they have a higher stent thrombosis risk. So these are the things that cause people to need to be on antiplatelets for a longer period of time, or that prevent you from saying to someone, "Oh, you only need to be on DAP for 6 months," right? So the short course. So things like, and it's again, it's pretty self-explanatory. So if you have like multiple vessels, you have multiple lesions, you have lots of stents, you have a bifurcation stent where you have, a high risk of thrombosis developing in this area where the stents are crossing over. You've stented one of their bypass grafts. You've done a complex CTO PCI, and then of course, if you have a left main PCI, that's very proximal. So that's very understandable. You guys should never be making the decisions about the antiplatelet duration. Even we don't do it. It's usually made by the interventionalist, but this is just so you guys know that these are sort of the factors that go into determining if someone's antiplatelet regimen is going to be different than our standard. And then likewise, we factor in sort of their PCI complexity and we factor in their bleeding risks. And this, again, quite self-explanatory, and you wouldn't need to memorize these per se. But these are features that tell us this person has a high bleeding risk. We don't want to keep them on DAPT for very long. So if we can get away with it, we'll shorten their DAPT duration. So from the guidelines, they have these nice sort of flow charts that I've kept in all the slides so that you can refer to them. But essentially, if you have someone that's had an elective PCI, so someone who's had stable CAD as an outpatient, but you can't control their symptoms well with anti-anginals, and they come in from home in the morning just to get a stent, and they're going to go home. That's kind of like your low risk category patient. Those are the people that you can get away with doing 6 months. So now your standard therapy is 6 months. If you have those high risk features, right? So if you had a complex CTO or something like that, then you can extend it. But you can also more comfortably de-escalate this population as well. Okay. The standard regimen that you're going to use for elective PCIs is always going to be aspirin and Plavix. We don't have that much evidence for ticagrelor or prasugrel in these populations. So aspirin, Plavix, 6 months standard for elective PCI. Now for ACS, our standard as we practice right now, so this is easy to remember, is 1 year. This is 1 year of DAPT. We do have a preference based on all the studies that have been done for ticagrelor over clopidogrel, or even prasugrel over clopidogrel. Now, Ticag and prasugrel are fairly equivalent. So you would be okay sort of choosing aspirin as your first antiplatelet plus one of those P2Y12 inhibitors, either Ticag or prasugrel. You can choose clopidogrel if the person has a high bleeding risk, for example, or they have some sort of contraindication to any of these, to Ticag or prasugrel. If you have high bleeding risk, from that sort of diagram I showed earlier, you can de-escalate them to single antiplatelet, which typically is either aspirin or P2Y12, or you can actually switch their second antiplatelet to clopidogrel. So you can use aspirin clopidogrel in the situation where they have a high bleeding risk and you want to de-escalate their dual antiplatelet therapy. Similarly, if you look at the leftmost column, if you have high angiographic risk, like that table we looked at, you can technically consider DAPT up to 3 years. And typically you'd want to use ticagrelor. Just notice that the dose is slightly different. It's 60 milligrams BID, or you can do aspirin plus Plavix, or you can do aspirin plus clopidogrel, plus prasugrel, sorry. Again, you don't need to, I know it's a little bit overwhelming to see all these different options, but the principle is ACS, still 1 year, aspirin plus either Ticag or prasugrel. and then, de-escalate or escalate depending on the patient. And this is the Plato trial, which is basically showing us why we choose Tycag over Plavix, but there was essentially reduced CV death, stroke, without actually increasing the overall bleeding risk. So that's a fairly strong recommendation now, is to use those P2Y12s over Plavix. Now, this is a question that shows up a lot for some reason, is the antiplatelet regimen post surgeries and interruption. And so initially when you see those questions, it's a little bit like jarring, because you're being asked to make like surgical decisions, but it's actually quite straightforward. Remember that if it's an urgent or emergent surgery, you're not going to stop them. Like, doesn't matter if they're on DAPT, whatever. They like absolutely need that surgery, and they're probably going to die without that surgery. So you're just going to proceed to surgery, and you're going to say like, surgeon to determine when to restart antiplatelets post-surgery when it's safe, whatever. The place where we sort of get involved is in these elective non-cardiac surgeries. Usually, you want to delay any sort of intervention, and you want to basically delay holding DAPT for at least the first 1 to 3 months. The guidelines say 1 to 3, but really most of our recommendations would be 3 months. So if someone is able to avoid having their procedure for 3 months, that would be ideal. After 3 months, you can then, hold, peri-procedurally hold your second antiplatelet if needed, and you can feel a little bit more confident that that stent has endothelialized. The problem is if you hold your antiplatelets early on, your stent hasn't fully endothelialized in the vessel, and your risk for stent thrombosis goes up by a lot. And so you usually want to wait at least 3 months. That's probably the safest. Questions you'll get is kind of like a cancer surgery that's semi-urgent. You don't really want to wait 3 months. In those situations, you could probably do 1 to 2 months. But it always has to be, you want to say like it's a discussion with the surgeon and the patient about sort of the risks and benefits. And then, aspirin, you should be able to continue throughout the peri-procedural period. And so you don't really have to hold it. It's your DAPT that your second antiplatelet, sorry, that you're going to want to hold, usually for sort of a few days at least. Usually it's 48 to 72 hours before you have your procedure. And for CABG, you can't really take anyone. I mean, surgeons do it, but typically, as per the guidelines, you should not be taking someone who's been loaded with a P2Y12 inhibitor for a CABG surgery, unless you've held their clopidogrel or Tycag for at least 48 to 72 hours, up to 5 days for clopidogrel. And again, you can continue aspirin peri-procedurally. And this is, I think this might be sort of the last piece on the antiplatelets. This gets a little bit complicated when someone has had a recent stent and now they have AFib. So whether they had pre-existing AFib or new AFib or really any other indication for anticoagulation, whether that's a PE, DVT, or in our case, it's usually AFib. So we'll talk mostly about the AFib scenario. Key thing to remember is that when you have someone on a DOAC, you can only sort of second antiplatelet you can use with them outside of aspirin is clopidogrel. You should not use a DOAC plus Tycag or prasugrel. Okay, so that's the main thing to remember. You probably have some experience doing this, so this might just be repetition, but what we do is, someone has had a PCI, they have AFib, and they have an indication for anticoagulation. We initiate triple therapy. Triple therapy can sort of last for up to 1 month. Before in the guidelines, it was up to 6 months. But now we say usually it's 1 day to 1 month. And so we keep an OAC on board, aspirin plus clopidogrel. And then we de-escalate them usually like, there's no sort of wrong answer. You could stop it after 7 days. You can stop it after 14 days. It's kind of based on what your general sense is of their bleeding risk matched to their thrombotic risk, depending on what their stent looks like. And then you would de-escalate them to dual pathway, which is clopidogrel plus apixaban, rivaroxaban, whatever it is you choose. And then after usually about 1 year, so usually continue on the dual pathway for about 1 year, and then you can discontinue your P2Y12 inhibitor and you leave the person on an OAC alone. So that's really the only circumstance that someone has had a stent that they're not going to be on any antiplatelets is if they're more than 1 year out and they're now on an OAC. Okay. I'm going to skip over this, but the slides that we've made just for oral exam review, I think these are like always very high yield, easy points to get when you're doing an oral exam. You just basically memorize this and just quickly rhyme all of it off, and you get points for saying all of this. It's very important. These are things that we know have clear benefit post ACS for secondary prevention. And so I'm just going to leave this slide here for you guys to look up there. The only thing is, just in terms of the medications, we'll talk maybe at the end, if we have a little bit of time, we can talk about the nuances of beta blockers post ACS. But do come back to review that. And then this is kind of just a summary again of when to start some of these medications post ACS. And so we know that ACE inhibitors, you want to start as early as you can. Usually want to avoid beta blockers for the first 24 hours if you have ongoing heart failure. But you do want to start it early and you want to start it before discharge at least. There is some discussion about the use of MRAs. So there's been sort of conflicting trials on whether there's a benefit of spironolactone. It has not showed up in the guidelines yet officially. So I wouldn't necessarily mention that if you're asked. But ACEs, beta blockers, and statins are the core medications you want these patients on post. And that's just for your reference after. Now, these questions do show up. The new CCS guidelines on driving are quite extensive and they cover a lot of topics. You do not need to know all of the situations. There's a lot about like post ICD shock, syncope, device upgrade, all of that. That's definitely in the realm of cardiology, so I wouldn't bother learning all that. The two sections I would read that I think is high yield for you guys is the section on ACS. So knowing how to counsel your NSTEMI patients about when they can return to driving, as well as the syncope ones about, when can someone who's had vasovagal syncope start driving again. And so we'll talk about that actually in the next slide. I think I have the syncope guidelines, and then we'll talk about it again at the end. The main principle to remember when talking about the driving guidelines is that you really want to look at what that ejection fraction is. So if you'll notice, it doesn't really matter if you had an NSTEMI or a STEMI. If your EF is less than 40%, meaning you have a higher risk of, of syncope, of sudden cardiac death, of arrhythmia, your private driving restriction is going to be 1 month and your commercial driving restriction is going to be 3 months. So that's fairly easy to remember. Likewise, doesn't matter if you're an NSTEMI or a STEMI, if your EF is greater than 40%, then it's a 2-week, 1-month restriction for both. Okay. And then unstable angina usually has a 2-day restriction and a 7-day commercial driving restriction. And so this is usually like the main reason why, sometimes you'll feel like, oh, the unstable anginas don't necessarily need an echo, or like the NSTEMI doesn't necessarily need an echo, but I always get them for this purpose so we can counsel them appropriately about their driving restrictions. There's a lot more detail in the document, the actual guideline. So feel free to refer to that if you're sort of confused about the nuances of that. And then regards to syncope, this is fairly straightforward to remember. So if someone's had one episode or a few episodes of vasovagal syncope that you think, remember, you know it's vasovagal based on their history. So the history is always going to be very important. Then you have no restriction. Um, the longest restriction for sort of is for syncope that's completely unexplained. So there's no clear vasovagal cause. There's no sort of situational trigger. Those people, you're a little bit more worried about something like a cardiac syncope. And so if you're, unexplained and you've only had one episode, you're not allowed to drive for 1 week. But if you've had recurrent episodes, you have a fairly long driving restriction, which is about 3 months. So I will just sort of move on, but those are, I think, the two highest yield sections of the driving guidelines. Okay, so just wanted to talk briefly about some post-MI complications because I do think this shows up. The biggest ones being, heart failure, pulmonary edema, things like cardiogenic shock. Arrhythmias are not infrequent around the peri-ACS period, whether those are, I think most of us think of things like VT or AFib, but also remember that if you have an inferior MI, it is not uncommon to have things like heart block or sinus bradycardia. And one of the things, I just wanted to sort of remind you is like if someone shows you on an oral scenario or even in a written, someone shows you an inferior STEMI, always make sure that you're not missing a heart block. Sometimes your eyes will sort of just focus on the ST elevations, but always sort of start from the beginning and say, am I missing any conduction abnormalities? Because it's quite common that we see heart block that's transient. It resolves with revascularization, but it's something you just want to pay attention to. Okay. Next, sort of mechanical complications. These are useful to just be able to sort of rhyme off. These are mechanical complications of MIs that usually occur in late presenting MIs, things like papillary muscle dysfunction or rupture causing severe MR. So that type of patient is presenting with acute pulmonary edema because of that MR, and their left atrium has not compensated at all since it's acute. And so those people are in flash pulmonary edema, ventricular wall ruptures. Often they present with syncope, hypoxia, RV infarction. Those are often hypotensive. You want to keep their RVs full because the RV is a floppy chamber and requires volume to be able to function. And then LV aneurysms and LV thrombus. And then finally, things like pericarditis post-MI are also not uncommon. And we'll talk a little bit about that in the pericarditis section. Okay, I'm going to just skip past this because it's kind of summarizing the same stuff. Let's take some questions. That's the end of sort of the ACS section. Next one is going to be stable CAD. But before we move on, I just want to make sure any questions so far.
This might be a stupid question, but uh, I guess like I know you don't need to know the grace scores, but I don't know if off the top of my mind if I remember like which one's like a high grace score, like generally. Do you know what I mean? Like the cutoffs. I think do you
No,
just use other hints?
yeah, I don't like whether you need to know like what is considered a high grace score and what is a low grace score. Is that what you're asking?
Yes, yeah, in a very
No.
roundabout way. Sorry.
No. I honestly I don't think most of us even know that. Like we'll just like plug it in, we'll look at the number and say is it high risk or low risk. But definitely like from what I remember, it didn't show up at all. Like I don't think you need to know the cutoffs for that. I don't even think you need to know the components of the gray score. I think it's mostly there for you to, I put it in the slides just so you can sort of in your mind when you're trying to assess whether a patient is high risk or not, those are the features that you should be looking for. But no, don't bother memorizing that.
Perfect. Thank you.
Yeah. Any other questions? Okay, you guys let me know when you need a break. Otherwise we can power on. Okay, stable CAD. One second, I'm going to refill my mug. So, stable CAD, we have a couple of guidelines that discuss chronic coronary disease. I think this one, if you're going to look at anything, the 2023 AHA guidelines for management of chronic coronary disease is probably the most useful because it kind of summarizes everything. The CCS ones are like a little bit old now. And so I would look at this most recent one. And even just looking at the tables is probably useful. And you don't necessarily need to read the text in that. But this is actually from a separate guideline about evaluation of chest pain, but we're going to talk a little bit about how to manage stable CAD and how to determine what sort of ischemic workup someone gets when they present with chest pain, what their evaluation should be. So I liked this table from last year, so I've just left this slide in for you guys to study from. But it's really about determining what kind of test to order for someone. And so we'll start off here saying sort of the first things you want to do when you have a patient that you suspect has CAD is first you want to establish the diagnosis of CAD. You want to determine if they're going to need to go for a coronary angiogram. And we do know this is the population where you probably hear your staff say this all the time is like, there's no benefit of revascularization in someone who has stable CAD. Okay, so that's not for the NSTEMI population, that's not for the STEMI population, but for people that have stable CAD, there is no mortality or even symptom benefit in most patients to get revascular, I can't even say it today now, revasked early as opposed to just using medical therapy. And so what you want to do is be able to identify high risk features where you're going to want to send that person for an angiogram. And you want to, most importantly, treat anginal symptoms. So this is like the cornerstone of stable CAD is risk factor management and treating their angina. When you're talking about diagnostic workup, we kind of categorize this is like honestly, this is probably the most confusing part of a cardiologist's day is figuring out what type of testing to send someone for. Someone who's having chest pain. And so the way you're supposed to think about it is really, there's two types of testing you can do. You can do functional tests and you can do structural tests or anatomical tests, right? So functional tests are ones that you get, you change something in the physiology, the hemodynamics of the patient, and then you see what happens either on the ECG, in terms of their perfusion, on their echo. And then structural is such where you really are just taking kind of stills of their anatomy, but you're not getting a sense of what's happening with changes in a patient's hemodynamics or physiology. Stress testing is absolutely in the purview of internal medicine. And so this is something probably worth knowing fairly well. So the whole point of stress testing or any of our diagnostic tests that we do for an ischemia workup is to be able to detect the presence of any functionally significant flow limiting coronary artery disease. Okay. And so usually whenever you're given a sort of situation in real life or on the exam where you're trying to figure out the right test to do for this patient, if that patient has no contraindications to exercising, meaning if they're able to exercise, and they're not like wheelchair bound or something, you should always stress them with exercise. Um, because out of everything, in terms of all the information that you get out of a stress test, the number one most useful prognostic indicator is that person's functional tolerance. And so if you have someone that does a stress test and they're only able to, exercise to like 1 met or like a few minutes, and then they have to stop for whatever reason, whether that's chest pain or fatigue or whatever it is, that predicts poor outcomes and higher mortality more than really any other feature outside of like them arresting on the actual machine. So stress them, exercise, make them exercise if they're able to. Okay. If they're not able to exercise, then we can pharmacologically stress people. And that is kind of suboptimal. It's something we do often, but it's not the same thing as exercise. So if you're able to put them on the treadmill, do so. If not, you have the option of doing pharmacologic testing. And so, as you know, we can do a dobutamine stress echo, we can do persantine with a MIBI, and we can use other vasodilators, which we don't use at our site. But those are all possibilities. And then you have to decide on what modality of test you're going to use. So are you just going to do a exercise, just a plain exercise test with an ECG? Are you going to do a stress echo? Are you going to do a MIBI? And we have, our SPECT and our PETs as well. And so our PET scans are kind of a combination of both anatomical and functional testing. I have a table later that you guys can look at that basically talks about the indications and contraindications for these modalities. And I do think it's important to know those. And it's really the contraindications to when you'd put someone on a treadmill, from what I remember, does show up. And so that's a useful piece to remember. So if you have someone, as I said, who's able to exercise adequately and they have no contraindications, then you're going to look at their ECG, right? And because the diagnostics of a exercise test really depends on how useful your ECG is going to be. Um, you look at their ECG. If it's normal, yeah, go and do an exercise stress test. That's great. If your ECG is abnormal, you want to ask, what are the abnormalities? And so the things that make you unable to adequately interpret an ECG, you'll see that it says like a left bundle and ventricular pace pattern. So that's like number one. If someone has a left bundle, I'm not going to get any information out of that ECG. So I'm going to want some other additional ischemic information. So those people could go for a MIBI where their perfusion is still useful, but their ECG may not be useful. Okay. The other things that are going to make your ECG difficult to interpret are if you have WPW, so if you have some pre-excitation, if you have pre-existing ST depressions that are significant, if you have LVH, because you already have LVH causes some ST depressions at baseline, or if you're on digoxin and have ECG abnormalities associated with digoxin at baseline. And so those are some reasons why you might pause for a second and say, am I actually going to get the information I need out of the stress test? And so you can sort of work your way down these pathways to say what is going to be your best modality of ischemic workup. Okay. When we're actually putting someone on the treadmill, this I think is useful for you guys to know because many of the stress tests in the community are read by internists. So this is totally within your sort of scope. Treadmill exercise stress testing, the sort of number one thing you want to achieve is actually make it diagnostic. And so the way you make that test diagnostic is getting the patient to get to at least 85% of their maximally tolerated heart rate, which is calculated by just saying 220 minus their age. If they're not able to meet that, you can still get some information out of the ECG, right? So even if they're, say they reach like 70% of their maximally tolerated heart rate, but you see very clear ST depressions, ST elevations, they have VT, like that's still a diagnostic test. It's giving you some information that they have low threshold hemodynamic instability or whatever. But for a test to be truly complete and diagnostic, you'd want them to reach at least 85% of their maximally tolerated heart rate. A positive test is one where you have greater than 1 millimeter of horizontal or downsloping ST depressions. Okay, so in stress testing, the morphology of your ST segments is really important. And so this is what it means by saying horizontal or downsloping. So this is horizontal. You can see it's like totally a flat line that persists after you have to look after your J point. Then you count, and it's usually 2 boxes. You want it to persist 2 boxes after your J point, 2 small boxes. So that's a horizontal ST depression, or it's downsloping, meaning you can see this very clear sort of negative slope. Those are indicative of ischemia. This is the point where tests become equivocal. So many people, and especially sort of middle-aged women, have this non-specific upsloping ST depressions on their ECG. This is often normal and is not indicative of ischemia. So you kind of ignore these upsloping ones. Usually we comment on it in the report, but these are the ones that make us really worried and say, okay, this is a positive stress test. And that is what I will say about that. And so looking at the morphology of your ST segments. Just this last point about the inconclusive versus a negative test. So what I mean about that, if you have a patient that doesn't reach 85% of their maximal heart rate and they don't have any ST depressions, you should call that test inconclusive, right? So who knows, had that person actually reached their target heart rate, perhaps they would have had ischemic changes. And so that's where you should not interpret these to be the same. Inconclusive should prompt further investigation. So you should send them for something like a CCTA to see if they have coronary disease. You should usually not stop right there. Okay. I won't read all these out, but I would try to remember many of these. And I think the really important things to remember here is these high risk features of a stress test. So if you have obviously ST elevations, any amount of ST elevation on a stress test is abnormal. Those patients usually should get admitted and get an urgent angiogram. Any sustained arrhythmias, blunted blood pressure response. So always look at your blood pressures when you're looking at a stress test. You always want it to rise. If it drops, it means that they are highly likely to have multivessel or very proximal left main disease. So it's high risk disease. And then, ST depressions more diffusely if they're in more than 5 leads. If you have more than 2 millimeters of ST depression, especially if you're at a very low METs. And then there's the Duke treadmill score that we calculate. Don't memorize it. I don't think you need to know that. I think these points are the ones that are important to remember about high risk tests that you're going to say this person needs an angiogram urgently. I'll talk briefly about nuclear scans. I don't think you need to know this in a ton of detail, but just the principle, you do order these tests. So just knowing when you're ordering them, the whole concept of the nuclear test is that we look at the heart when it's at rest, and then we stress them in some form, whether that's through exercise or with Persantine. And we look at the perfusion as, again, when the heart is stressed, and we look at the perfusion mismatch and say, okay, this is where it looks different when the person is stressed. This area of the myocardium doesn't look like it's perfusing. And so you're comparing these images to each other and saying, where is there a difference? Exercise is always preferred in these tests, but for those who can't exercise, it's a good option because you can actually get Persantine. Contraindications to this. So, if you're given a patient who has severe asthma that's like on pred, that's had like multiple admissions, those they're trying to tell you that you should not give this person Persantine. Um, and so just I would kind of just know these contraindications, but you don't need to know the logistics of nuclear scans. The only point I'll say about nuclear imaging MPIs is that the one sort of risk of MPIs is that it can miss multi-vessel disease. And it's because at rest you have, if you have left main and RCA disease, that means at rest, your perfusion's already going to look quite bad. And then when you stress them, it still looks bad. And so when you're trying to visually compare them, everything looks equally bad. So you may not even notice that there's any change because there isn't. And so, if you're very suspicious that someone has multi-vessel disease or very proximal left main disease, then nuclear imaging is usually not your best bet. You risk the chance of missing them, and you may get a false negative test. And so, those are people that you'd want to do usually something like a CCTA. You could even do a stress echo on them, but you don't want to do a nuclear. And so that's the concept of balanced ischemia, which you've probably heard people say. Now, coronary angiography. So these are our CCTAs, is what we call them. These are becoming a lot more popular, as you know. They are useful in a lot of settings. I think our indications are going to broaden for sure moving forward. But it's helpful sort of in two circumstances for now. For people that have some CAD and you're trying to risk stratify them. So, for example, they have some CAD, but you now want to see, has their left main disease progressed? Is this patient going to benefit from revascularization? Or someone that is presenting with sort of a low to medium risk type chest pain, and you want to see if they actually have coronary disease. And in those people, you can use a CCTA. It's different from a coronary artery calcium score, but you can get them in the same test. Um, you can also just get a coronary artery calcium score alone. That is useful for people who are sort of asymptomatic, intermediate risk, and you're trying to decide if they're going to benefit from aggressive risk factor modification. And so, you have this person, they're intermediate risk, they're not on a statin yet, their lipid targets are not really out of whack, and their LDL is not high enough to start a statin. It's reasonable to get a coronary artery calcium score and see what their coronary artery calcium is. And if it's greater than 100, then they'd actually meet criteria to start a statin. And so we use it kind of as a risk modifier to see if you can bump someone into a bit of a higher category of risk. The thing to remember for CCTAs is you don't want to order these for people who are old, because the older you are, the more calcium you're going to have regardless. And so the more calcium, if you have too much calcium in your coronary arteries, then you're going to have a lot of reverberation artifact, like basically reflection in the actual CT scanner. And so the people that are old and are already very calcified, not super useful in them. It's hard to quantify the degree of stenosis. It's also not helpful if someone's had stents before, because you're going to get so much artifact that you can't actually quantify degree of stenosis, and you definitely are not able to quantify what's going on in the stent. And so just be thoughtful about if you're going to order it, about who to order it in, as I should say. I'll leave this here for you to look at, but it's just there's a few slides that just provide a bit more information about when you're going to send someone for stress imaging versus a CCTA. So you can look at this on your own time. But it's never a black and white type picture, right? And you ask 5 different physicians what they would order, and like all 5 of them may say a different test, right? And so it is about looking at the patient, sort of trying to risk stratify them in your head, getting a Framingham risk score done, and then saying, okay, what is going to be the best test, and what am I going to do with the information from this test? But it's good to know what all your options are. And so I'll just skip by that as well. This is all about our different testing options. Contraindications, as I mentioned before. So just take a quick read of this. You don't need to know this in great detail, but just what the contraindications to each of these testing modalities would be. Um, and just from the choosing wisely guidelines, and I know most people sort of already know this, but patients without cardiac symptoms should not get routine stress imaging done. So we don't use it as a screening tool unless we have people that have the following criteria, right? So unless they're not entirely low risk and they're actually, people with these features, so people who have diabetes, if you're older, you have peripheral artery disease, or you have a reasonably higher Framingham risk score. Those are just some. But if you think that they're asymptomatic, but they're not entirely low risk, they're kind of in a low to medium risk. In those patients, you can use these types of tests, like a CCTA would be reasonable, for example, if you're just trying to really categorize them appropriately. But an asymptomatic low risk test, a low risk patient, you should not be ordering testing on them. Stable CAD management. Is, as I mentioned before, is as good, if not better, in terms of, sorry, medical therapy is as good, if not better, than actually revasking the patient. And we have a number of trials, including Courage and Ischemia, that support that. We know that people that had revascularization with CABG or PCI, there was more longer survival in people who had CABG if you had diabetes. PCI led to more revascularization attempts, and CABG led to more strokes. And so, really, if you can leave these people on good medical therapy, you can control their symptoms and their angina. That's probably the main thing you can do for them. Revascularization is only beneficial. So you have a stable CAD patient, you have them on all their meds. The only times when you should really be like, okay, maybe I need to send this person for an angiogram is if they have refractory angina. So we'll talk about some of our anti-anginals. So you really want to use all the anti-anginals in your arsenal before you're going to send them for a revasc. Um, or if they have really high risk disease. And so if they have a left main stenosis that you saw in CCTA, for example, or they have, multi-vessel disease and diabetes, or multi-vessel disease and LV dysfunction. Those people have had some benefit in revascularization. So it's not very many people that end up getting revasc if they have stable CAD. This is just summarizing the trials. I will be honest, like there's a bunch of trial information in these slides. I wouldn't like waste your time reading trials and what the outcomes were. I don't think they ask you those questions. And so it should be like on the last list of things you want to spend your time studying. Medical therapy, we know, can do two things. It improves your prognosis. If you're using these medications that we know have vascular protective effects. So people that have stable CAD need to be on aspirin. They should be on a high intensity statin with fairly tight lipid targets. Smoking cessation always, that's an easy point, and people always forget to say it, but always just smoking for anything. Someone's had a stroke, someone has PAD, someone has CAD, you want them to stop smoking. ACE inhibitor diabetes treatment, and just as you guys know, SGLT2s and GLP-1s, just to mention those in a sort of a cardiovascular protective role. And then the question about colchicine, as I said, there's been some debate about the use of MRAs in CAD. The most recent trial, though, showed no benefit. So again, hasn't made it into the guidelines. So just something to sort of use at the end of the line if everything else has failed. In terms of improving symptoms, this is important, like in terms of anti-anginals that you have in your arsenal. Beta blockers are most effective at improving angina type symptoms. We can use long-acting calcium channel blockers if they don't have, um, a ton of sorry, the long-acting calcium channel blockers tend to be amlodipine. You can use them with a beta blocker if they don't have any conduction disease, but you should avoid using them together, especially if you're using something like diltiazem. You should avoid using that in conjunction with the beta blocker. And then nitro patches, nitro pills, whatever sort of nitrates you can add on without dropping their blood pressure too much, are all effective anti-anginals. There's a number of new anti-anginals that are now available, like ranolazine and things like that. But at that point, that patient should be, referred to a cardiologist for refractory angina to see if those medications can help or if they need to go for an angiogram instead. Compass trial, I think everyone knows this trial quite well. But remember that the population that it includes is not just PAD, but it is also people with CAD, people with carotid disease, people with polyvascular territory atherosclerotic disease can benefit from the Compass trial regimen, which is rivaroxaban, just a low dose at 2.5 plus aspirin. So another regimen you can use in these patients. I'm going to skip over the Compass trial stuff. All right, we're at the end of this section. Any questions before we move on to heart failure? Do you guys want to take a quick break? I think we've been oh yeah, we've been at it for like 70 minutes. 5 minutes, 5 minute break. Thumbs up. Okay, let's do it. What time is it? Let's reconvene at 7:20. All right, I'll see you guys in a second. All right. Are you ready to get started? In the interim, did anyone think of any questions they wanted to ask about ischemic heart disease, stable CD, anything else? Okay, we will carry on then. All right, so heart failure, my favorite of all topics. In terms of guidelines here, Um, there have been a couple of new guidelines. In fact, there's a new guideline from 2025 published by the CCS, which you don't have to know because it's so close to your exam. I think it's usually like at least a few years before the exam, they stop incorporating new guidelines. But we'll talk about it just so that you know, even for practice. Most of this information is going to be from the April the 2021 CCS guidelines for HFrEF. And then there's some AHA updates as well. So we've incorporated all of those. I do think you guys are probably quite well versed with heart failure management because it's something we see a lot here. But we'll just sort of go over what the guidelines say about management and workup and all of that. So I'm going to skip this because this is for you guys to reference when you're doing the oral scenario. These are kind of like easy points about what you're going to do to, stabilize the patient. And then identifying triggers for exacerbation are always kind of like the most important part of your heart failure admission. And so I'll leave this here for you guys to look at in a bit once you're done your written exam. Um, Also for the oral, for in terms of the physical exam, and we'll start here then. So when someone's presenting with acute heart failure, in terms of the workup, things you want to be doing, again, review, you're getting your 12 lead, you're seeing, did they suddenly go into atrial fibrillation? Is their pacemaker or CRT device not working? Whatever it may be. You're getting a chest X-ray, um, and you're getting all of these labs, NT-proBNPs. I know people have sort of hummed and hawed about the utility of them, but we do know, and as per the guidelines, there is prognostic and diagnostic value to having a BNP. Remembering that in obesity, BNPs are falsely low. That's usually the one time when you just have to think a little bit more about your BNP numbers, and then troponins, and always you're getting an echocardiogram on these people. These are, I know some of the Royal College questions like to talk about sort of the JAMA rational exam, like positive predictive value of things. So I'm just going to leave that there for you to look at. But things that decrease the probability of a heart failure exacerbation is, like a normal BNP, completely normal chest X-ray, no crackles, and things that increase your probability is an S3. So that's quite a useful sound if you can hear it, is an S3 gallop. JVP, you're looking at your chest X-ray and looking for edema. Um, I realize that the quality of these images is kind of bad, so sorry about that. But these are from the CCS guidelines, which I think are really laid out nicely. You've probably seen like the CCS heart failure pocketbook. I think that's kind of like all you really need to read in terms of what you need to know for heart failure. You're looking at what sort of history they have in terms of important questions to ask is recent drug use or other exacerbating factors. And then you're doing your initial investigations, as we talked about, and the echocardiogram. So this was kind of just lays it out in a easier way to see. I just wanted to put this up, not because you necessarily need to memorize this, but it's just for you to, if you haven't seen this before, this is the Forrester classification of heart failure. And I just want to highlight the fact that heart failure is not just heart failure, right? Like there's so many different phenotypes. And people would argue that there's more than this many phenotypes, but this is really just kind of summarizing that Someone with heart failure can present in a number of different ways, and the way Forrester classified them that helps us because it gives us some prognostic information as well is with this cold, dry, wet, warm, dry, warm, wet classification. So the sort of typical heart failure that you sort of hear about or read about is the cold and wet, right? Someone is in sort of early cardiogenic shock. They're hypotensive. They have pulmonary edema. Their JVP is elevated. They have peripheral edema. That's a very easy to recognize heart failure. That's kind of your slam dunk. But there are phenotypes outside of this. So when someone is at this point, you can see that their prognosis is already very poor. This is someone who's kind of missed the window of early management. You can also have this cold and dry phenotype where they are poorly perfused, meaning they have low cardiac output. Their index is going to be low. They have a low blood pressure, but they're not congested. So, they're not going to have pulmonary edema. If you do a pulmonary capillary wedge pressure on them, it's going to be fairly low. So, it's just to say, don't be misled if someone looks dry, um, and they have sort of a low cardiac index. They can still certainly be in heart failure. Heart failure doesn't necessarily require someone to be wet. So that's the main principle that I wanted you to sort of think about. When someone is in this category, this is a bit easier to treat. When someone is wet, we can diurese them. They're congested. We need to give them Lasix, or whatever we need to do to get that extra fluid off. This is a bit more challenging when someone is dry because you can't. There's no utility of decongestion. These are the people that end up needing inotropes. They have overall poor pump function. It's more of a pump problem and not a volume overload problem. And although the mortality here says just 23 compared to 51, their long-term mortality in someone who has almost exclusive pump function is very high, highest of all these different classes. Um, PA catheters, you definitely don't need to know much detail about this, but the idea is that you want to do invasive hemodynamics in people that are definitely in this category and often in this category. So if you have someone presenting in those sort of categories, it's very reasonable for a PA catheter to be the next step to help ascertain the diagnosis, but also to guide management about how much decongestion versus inotropy they require. If you guys have a question about PA catheters, we can talk about it sort of at the end of this section, but I don't think it's going to be a significant any component of your exam. But the main idea of it is that you get your right atrial pressures, you get your right ventricular pressures, you're getting your pulmonary artery pressures, and based on that, you're determining what your left and your right heart filling pressures are to guide your management. In the guidelines, it kind of walks you through what to do in each scenario. And so this is the kind of the principles of, is this person warm and well perfused or not? So if they have adequate, someone's coming in heart failure, they have adequate blood pressure, you've already diuresed them, right? So first step is diuresis if they have volume overload. And then based on what their map is you're going to determine if they're going to need vasodilation. So if their blood pressure is adequate, they're not really responding to their diuretics, you need to help with some afterload reduction and vasodilation with nitroglycerin or nitroprusside. In the opposite end of the spectrum, if they're hypotensive, they will likely need some inotropy and maybe even some vasopressors. And if they're in this kind of middle category, these people you want to get a PA catheter in, and then add an inotrope as required. This is a helpful table because it puts a lot of information in one page. And so this is in terms of, and this is something you guys will see commonly, is a new onset heart failure. remembering that heart failure is a symptom of something else. So the question that we're always asking is, why is this person in heart failure? And they're coming in brand new. The most common cause of heart failure or, LV dysfunction in North America, at least, is ischemic cardiomyopathy. So certainly one of the first questions you want to ask is, does this person have CAD? Did they have an infarct? And is that why they're now in heart failure? Second most common is hypertensive cardiomyopathy. So you want to say, is this longstanding hypertension? Is this a hypertensive crisis? But you also have to think about all these many, many other etiologies of heart failure. So as I said, hypertension, CAD are the most common. Next after that are things like valvular disease. So does this person have, longstanding severe AS or MR or aortic insufficiency that went undiagnosed and now they've decompensated? Do they have some form of arrhythmia, whether that's atrial fibrillation? Are they having episodes of VT or PVCs, a high PVC burden, for example? So those are the top things you want to ask about. Not forgetting that there's things like chemotherapy that we'll talk about in detail, things like cocaine use or other toxins, peripartum cardiomyopathy, worth for you guys to at least know about the concept and know when it would present. So peripartum pregnancy history is always very important. Then we have our inflammatory infectious causes of cardiomyopathy and heart failure. So myocarditis can happen idiopathically, secondary to a virus, and they're quite fulminant processes. So those patients go into decompensated heart failure very quickly. Sarcoid, um, things like giant cell myocarditis. Probably don't need to know that, but it's worth knowing myocarditis and sarcoid at least. Metabolic causes, I think we all send for thyroid tests when someone comes in with heart failure, but knowing that there's things like adrenal insufficiency or FeO that you have to think about as well if the phenotype matches. It's not something we'd send automatically for anyone presenting with heart failure, but depending on what their history sounds like, it would be reasonable to do so. Nutritional deficiencies, rarely see that. Obesity for sure as a cause. And then our infiltrative disease, like amyloid, which we'll talk about in detail because that's a very common cause, especially now we're identifying it a lot more. And then genetic cardiomyopathy, so things like HCM or ARVC. So HCM is probably enough for you to sort of think about when we talk about genetics. And so I just wanted to, yeah, talk through that slide because these are always important to think about with a new onset cardiomyopathy, mostly because some of these are treatable conditions where you can actually reverse LV dysfunction. Some of them are not, but so, chronic heart failure management. We sort of talked about our etiologies. Most of these people with new LV dysfunction are going to need an angiogram to assess for CAD. It's very infrequent where we don't cath that person. And as per the guidelines, you do want to rule out coronary artery disease. You want to get their NYHA classification and their quality of life. So you're quantifying their degree of disability, and then you want to improve their symptoms. So you're going to ask them to salt restrict, fluid restrict. You're going to ask them to go to cardiac rehab if they qualify, and you're going to use diuretic therapy for symptom improvement only. Remember that diuretics do not improve mortality in heart failure, only symptom benefit. And then we want to improve survival, most importantly, and decrease hospitalizations. And that's when our GDMT comes in. So these are the older 2021 guidelines. These are our newer guidelines, not the newest guidelines, which are the 2025 ones, but these are the ones that you should know. And so I think everyone knows this in and out. You want people on an ARNI, and if they can't tolerate an ARNI, then you're using an ACE or ARB. You're using a beta blocker. And the specific beta blockers we'll talk about, but there's only three that have been studied in detail. Then we want to use an MRA, and we're using an SGLT2. You're going to see if they are candidates for additional therapy. So usually the practice is you get someone on these, four pillars of heart failure management. Everyone should be on these four unless they have a contraindication or an intolerance. And then if you find that they still have symptoms or their LV function is still dropping, or they're having ongoing hospitalizations, then you say, are they going to be a candidate for something else? So ivabradine, just remember, like you don't need to know too much about it, but just remember, consider ivabradine in someone that's been on all their GDMT, they still have symptoms, and most importantly, they have a heart rate greater than 70 and they're in sinus rhythm. So ivabradine is basically a sinus nodal blocking agent, and it just reduces the rate that your sinus node is firing. It just slows your heart rate down. It has the same effect that a beta blocker would, right? So we know that people in heart failure or people who have heart failure benefit from some reduced heart rates because you have less oxygen demand and improves things from like a remodeling perspective. And so that's the utility of ivabradine. It can cause AFib. And so you want to not use it if someone is already in fib. And it only works if it's the sinus rhythm that's firing and causing that conduction to happen, right? And because it works on the sinus node. So that's like the only thing I'd remember about it. Heart rate greater than 70 and sinus rhythm, you can consider it. Usually these medications are being started by cardiologists, but and then there's vericiguat, which is like just come to Canada. It's quite new, used mostly in the US. If they've had a recent heart failure hospitalization, you can consider it. That is basically an additional afterload reducing agent. It's a sort of a vasodilator, works as a vasodilator. In certain patients, in the guidelines, they say Black patients on optimal GDMT or patients that are unable to tolerate ACEs or ARBs or ARNIs, you can consider hydralazine and nitrate. So usually it's isosorbide dinitrate and hydralazine together. And then digoxin you can use in suboptimal rate control if they have AFib. It is an inotropic agent as well, so it helps with the pumping function. And so you add these additional therapies if you think you need them. You reassess their LV here, and then you classify them are they in which NYHA class they are in, what their EF looks like, and then you say, do they need a device or not? So that's usually the stepwise approach, or GDMT, any additional therapies, and then devices. So we'll talk about devices in a second. First, we'll talk about the medications. I'm not going to talk about this in detail. I think most people know how RAS inhibition works. But we know that there's significant mortality benefit in these patients. These are the studies for like Entresto that showed benefit when compared to ACEs and ARBs. And so it is always our first line therapy. Remember when you're starting things like Entresto or MRAs, if it's like an oral scenario, just say that you would check creatinine and lights in 1 to 2 weeks after initiation, because you just want to make sure that their kidney function and electrolytes are not deranged with the initiation of these medications. I am going to skip past this. This is for you to read if you really care about the studies. SGLT2s, we know it's a foundational therapy in patients with HFrEF. It's also now a foundational therapy in people who have HFpEF with a preserved ejection fraction. Mortality benefit reduces hospitalization for SGLT2s. Remember that they are contraindicated with if you have type 1 diabetes. And then I do believe that sometimes they will potentially ask you to do some counseling about initiating these medications. So the biggest thing for SGLT2s is remembering that they increase your risk of genital mycotic infection. So that's usually fungal infections, not necessarily your run-of-the-mill UTIs. And it can increase your creatinine a little bit and decrease your eGFR. And then importantly, counseling patients around sick day management, that they should hold their SGLT2s if they are feeling unwell and not eating. MRAs, we know usually it's things like spironolactone or eplerenone or finerenone. Those are our three main mineralocorticoid receptor antagonists. We know that there is clear benefit in patients who have reduced EFs and NYHA class 3 to 4 symptoms. We start them in patients regardless of their NYHA class. And then, as I said, there is this some signal of post-MI benefit, but the main thing to remember is it's beneficial in people who have a reduced ejection fraction. Next is that of beta blockers. Main thing to remember about beta blockers, two main things. The beta blockers that were studied in the heart failure population were long-acting metoprolol, so not the metoprolol we use in the Hamilton General. So it's a long-acting metoprolol, carvedilol, and bisoprolol, and those are the ones that were shown to reduce morbidity and mortality. Um, you don't want to start. So, if someone comes in, they're in decompensated heart failure. As you know, you do not start beta blockers in people that are still decompensated and haven't been adequately decongested. And so you start them in people who have become euvolemic. And the thing I'll say about these medications is that outside of your beta blocker, the recent guidelines do say that you can start a lot of these medications simultaneously. So you usually want to start them in parallel at low doses. You don't necessarily need to do them one at a time. You start them at low doses. You try to aggressively up titrate. We do know that we should start them pre-discharge if possible, and your beta blocker should come on before you discharge the patient from hospital as well. And then they need close monitoring after they leave hospital. And try to get them to their target doses by 3 to 4 weeks post initiation. Okay, these are just sort of your target doses for you to look at. I don't think you need to memorize these, but it's just, if you're going to mention a medication when you're doing your oral scenarios, it's useful to know. They may ask like a follow-up question about like what dose would you give? And so some of the common ones, definitely don't need to know all of them, but like it's helpful to know what ramipril dose you would start or what candesartan dose you would start, especially if you're, offering that as something you're going to do. Okay, devices. Any cool, you know what? Let me finish this section and then we can do questions. So devices in heart failure. A few things to remember. So this is talking about primary prevention devices in heart failure. We'll talk about secondary prevention a little bit later, but the things you want to memorize, sort of the key principles, is before you think devices, you want someone to be on GDMT for at least 3 months. So you first want to see, are my medications working? Can I get their ejection fraction to above 30, 35, and above? And if so, then this person doesn't need a device. Okay, so you want to keep them on for at least 3 months. And the little star there is if they're post MI, you want to wait at least 1 month post MI as well. Okay. But 3 months is the main thing you should remember. And once they've been optimized for 3 months and their EF is still less than 30%, they should get a device. Okay. So that's kind of like this bottom category here. So, ischemic cardiomyopathies, any NYHA class really outside of NYHA 4, and then EF less than 30%, you should give them a ICD. Then you want to ask your question is, do they get an ICD or do they get a CRT, right? So once you've determined someone's going to get an ICD, you want to say, will they benefit from a CRT or will they benefit just from a regular ICD? So we can talk a little bit about the benefits of a CRT. The other people, so if you're less than 30, it's kind of a slam dunk. You're going to get an ICD because your risk of sudden cardiac death is high. If you're kind of between the 30 to 35 range, right? And so if you're kind of like in this top category, these two, whether it's ischemic or non-ischemic, you want to look at your NYHA class. And if you're sort of NYHA 2 to 3, then you should get a device. Okay. You can see here that it says no stage 4. So if you're NYHA class 4, um, that usually confers that your prognosis is going to be likely less than 1 year. You're not going to benefit from an ICD, and you're actually probably going to have more harm from an ICD with inappropriate or even appropriate shocks. And you're not going to derive much long-term mortality benefit. So remember, an ICD doesn't improve symptoms. An ICD is there as a backup if someone has a sudden ventricular arrhythmia. So numbers to remember: 3 months of GDMT, EF less than 30%, or EF less than 35% with NYHA class 2 to 3. Okay. Indications for a CRT, right? So you've determined this patient needs some form of defibrillator device because they're high risk of sudden cardiac death. Then you just ask the question, and really you're asking EP this question, but the question is are they going to benefit from resynchronization therapy? So the whole concept of a CRT, if you haven't seen one before, is that instead of there just being a lead in your RV that's shocking your heart if it needs it, you also have basically a pacemaker lead in your coronary sinus that's pacing your left ventricle. And the purpose of that is to try to create synchrony between your left ventricle and right ventricle, try to make it more physiologic. So when you look at a paced rhythm on an ECG, you see your QRSs are super wide. And that's not really a physiologic way to pump. And we feel that the stroke volume is impaired because there's no synchrony between your left and right ventricle. You have better contractile force if your ventricles are contracting together. And so the concept of the CRT is that we can pace the left and the right together, create this narrow QRS, meaning we have more concerted contraction between the left and right, and that we hope that improves symptoms. It usually doesn't improve your EF by any significant amount, but it does improve symptoms because you have sort of an improved stroke volume. So when you decide they need an ICD, you're going to say, well, do they meet any of these criteria? Do they meet all of these criteria? Sorry. They should be NYHA class 2, 3, or an ambulatory class 4, meaning like they're class 4, but they're walking around and there's some hope of recovery. So if they have like a myocarditis that's reversible, that's someone you may consider. Then you're optimized your medical therapy for at least 3 months. You have an EF less than 35%. And importantly, you have to have a QRS that's greater than 150 milliseconds with the left bundle branch block pattern. So those are two very specific criteria that often are the reason why someone wouldn't qualify for a CRT. And you want to have underlying sinus rhythm. There is some weaker recommendations about sort of right bundle morphologies and QRSs that are less than 150 milliseconds, but I do think that's out of the scope of your exam. So that's the main point about devices there for primary prevention in the setting of heart failure. I will leave this here for you to look at. It's just basically what I talked about in flowchart format. HFpEF. So much more challenging of an entity to manage, mostly because we don't have the same medications with the same efficacy in preventing mortality and rehospitalization. But it does compose like 50% of the heart failure people we see. So it's certainly prevalent. More common in older patients, females, patients with hypertension. Symptom management wise, we use diuretics if they need. These patients often don't require diuretics though, because they don't have a ton of congestion, as they do have adequate forward flow, and they usually don't need diuretics until they go into an exacerbation. Um, Standards of therapy. I'll show you on the next page the new updated 2025 guidelines, but MRAs, SGLT2s. So MRAs kind of like your number one thing you want to start. Sorry, SGLT2s are the number one thing you want to start. MRAs have showed some benefit as well. GLP-1s have also showed some benefit. So now they've showed up in the guidelines, as well as ARNIs now have a class 2B recommendation. So it would not be wrong to sort of start someone on all of those four therapies for someone who has HFpEF. You want to treat any of their other cardiovascular risk factors. Obesity is one of the most common causes of HFpEF. And so GLP-1s offers, sort of a significant benefit in these populations, not from just a weight loss perspective, but also improving their heart failure. And that's what I'll say about that. And so these are the new guidelines that I just put in here, just so you can see here on this side, you can say like SGLT2s, MRAs must be started in these patients, EFs less greater than 40%. And then patient specifically, you can consider ARNIs, you can consider GLPs, okay? And so while this probably is not testable in terms of on your written exam, I doubt something like this would show up. I do think it's useful to be able to sort of have this in your back pocket in the setting of a oral scenario where you're talking about what medications you'd start. Just for your interest, not going to be on the exam, CCS recently in their guidelines changed the terms for how we define heart failure, which led to a little bit of controversy. But basically before, what we called HFrEF is we had I'm just trying to see how they wrote this. Previous terms. Oh yeah. So previously they would have HFrEF, so heart failure with reduced ejection fraction, and that's remained the same, but they've basically gotten rid of this mid-range and preserved ejection fraction. So they don't really care if you're in that mid-range 41 to 50%. They said ultimately, we're not treating these patients any differently, even though the phenotypes of them range quite a bit. We're just going to categorize them into one main category that is heart failure with non-reduced ejection fraction. So take that as you may, but just something interesting for you to know. Okay. Questions before we move on to cardiomyopathies. Oh, I realize I haven't checked the chat.
Hey, Pocky. I just wanted to quickly ask about like the guidelines that will be specifically used for our written and oral exams. It sounds like the 2025 guidelines might be too new to actually be in the written. But what about the oral? Like if you were given a question and asked about management, should we be referring to the 2025 guidelines or the ones from before?
I don't officially know how they'd structure the oral, of course, but I suspect that the expectation, so the expectation would be based on the older guidelines. So if you were to quote the older guidelines, I think that's not a problem. I don't think you would lose points for saying something that's out of the most recent guidelines, right? So if it's something very straightforward that like any of the examiners would probably know that there's an update to the HFrEF guidelines or HFpEF guidelines, knowing that MRAs and SGLT2s are now equally beneficial in HFpEF. If you sort of quoted that, I don't think they could reasonably dock you points. But I think from what I remember historically, they would not include guidelines that are more than 2 years old. That's what I remember hearing. I don't know if that's true or not. More than 2 years old in the exams. So it would not be reasonable to expect you to be able to answer questions about the 2025 guideline. 2023 like antiplatelet guideline is fair game, but anything after that, I don't think so.
Okay, thank you so much.
Yeah. It's always very challenging knowing like up to what guideline am I going to read and like what am I going to commit to. But I think they're usually fairly reasonable in terms of, not making the multiple choice questions very stringent around depending on which guideline you read, and they're more sort of general management questions. Yeah. Any other questions about anything we've talked about? Dario, sorry, I saw that you had a question from before about beta blockers in CAD. So yes, I said I was going to talk about this. So the big question, and recently there was a trial that came out of Europe about beta blocker use in CAD, and especially in the ACS population. And I think that's probably what you're referring to as ACS. But basically, it's around the timing of or the length of time that you're going to treat someone with a beta blocker. So, as per the guidelines right now, basically all comers with ACS events should get beta blockers. People that have a persistently reduced ejection fraction should obviously remain on beta blockers. People who have a recovered ejection fraction typically can stay on a beta blocker for 1 to 3 years, and then you can stop it. So basically, they don't need, if your ejection fraction has recovered, you don't need lifelong, like long-term beta blocker therapy, which is different than, your statin, your ACE inhibitors, those you're typically leaving on lifelong. So that's the big difference. The whole European study that was done was really around using beta blockers acutely post ACS, showing that there may not be a benefit if the ejection fraction is preserved. But that has not made it into the guidelines yet, and I'm not sure it will. And so I would really not quote that in I would not use that to guide the way you answer your questions. Okay, we'll carry on. We have about 1 hour left. Cardiomyopathies. We talked about this. I kind of like touched upon this when we were discussing our work up to acute heart failure. So cardiomyopathies, there's different phenotypes that we categorize cardiomyopathies into. We have our dilated cardiomyopathies, some of which are reversible, like alcohol-induced or Takotsubo, some of which are not. Then we have our restrictive cardiomyopathies, which involve basically infiltration or restriction of your myocardial tissue or your pericardium. And then you have your hypertrophics, which are also vary quite a bit, but those are often genetically linked cardiomyopathies. We'll start with HCM. As we move on through the talk, these are lower and lower yield things that are going to show up on your exam. So you may get like a question here or there, but you don't need to know these concepts in detail. The biggest thing I'd remember for HCM is the physical exam, because I do think that's good for you guys to know. Knowing that what maneuvers make it better, what maneuvers make it worse. So we'll talk about that. But HCM is basically this autosomal dominant genetic condition. They have both a obstructive and a non-obstructive variant. And so not all HCM is HOCM. It is only called HOCM when there is a clear LVOT obstruction that is visible either on echo or on cath. Usually they present with shortness of breath, they have syncope, and they'll have exertional chest pain, arrhythmias, and then they'll go for a cath, they'll have clean coronaries, and their echo will show a very thick myocardium. Physical exam wise, so very much like an aortic stenosis, the sort of classic question is like, how are you going to distinguish hypertrophic cardiomyopathy from AS and vice versa? But the classic sort of systolic murmur is a crescendo decrescendo murmur, best heard. This one is heard more at the apex in the left lower sternal border, and it gets louder with any maneuver that increases the preload it gets better with any maneuver that increases the preload to the heart, and it gets louder with anything that decreases the preload, right? So we know that the more filled your LV is, the better your obstruction is going to be. You're basically stenting open your LVOT and your obstruction is going to get better. So when you think of it sort of physiologically, it's sort of easy to remember what's going to happen with your murmurs, depending on what maneuver you do. Main principles of management for HCM is to avoid hypovolemia. You're counseling them to avoid competitive sports, first degree cascade screening of family members, and medical management really is just beta blockers. And so you're trying to increase your diastolic filling time so that you can have as much preload in your LV as you possibly can. And then if those management strategies are not effective, so if someone is still symptomatic, had an episode of syncope, despite having beta blockers on board, then you want to do interventions, whether that is percutaneously via a alcohol septal ablation, where you basically ablate the septal coronary artery, septal branch of your LAD, and you want to kill off that myocardium so it stops growing into your LVOT, or you do a surgical myectomy where you actually cut off a part of the myocardium so that you clear that obstruction. Important to remember is that you're anticoagulating. It's one of those few scenarios where, regardless of someone's CHAD score, someone with HCM comes with atrial fibrillation, you're going to anticoagulate them. And again, these patients are very preload dependent. And so you want to make sure that they have adequate hydration at all times. Again, this is kind of more in the realm of cardiology, but just like a little thing for you to remember is, HCM people have a high risk of sudden cardiac death. I should think about ICD implantation. So it would be reasonable to be like, I'd refer this patient to cardiology for assessment of ICD candidacy. We essentially use a few scores to determine what someone's sudden cardiac death risk is. And those high risk features include if they've had a family history of sudden cardiac death, if they've had unexplained episodes of syncope that were not vagal, if they've had ventricular arrhythmias on their Holter monitor, prior cardiac arrest, of course. And there's some specific features that we look on MRI and echo, depending on like what their septal thickness is, how much late gadolinium enhancement they have, things like that. So suffice it to say, they should be evaluated for ICDs. These are our management strategies for HCM. And so we talked about the beta blockers, or we use our calcium channel blockers, including verapamil or diltiazem. At that point, if they're still symptomatic, you're referring to cardiology, even earlier, in fact. Medications that we use for HCM. So we talked about sort of these two options. Mavacamten is an actual medication, drug therapy that we can use that is actually quite effective if your EF can tolerate. So it's not used in people with a reduced EF. It can actually cause people to have to develop HFrEF, people who didn't in the past. And so that's one of the medication options we have, or disopyramide as well. Don't need to know any of these medications in detail. I think it's useful to know that they exist. So if you see the word mavacamten, you can kind of put together that this might be an HCM. Cardiac amyloid, we're seeing a lot more of. It's one of our infiltrative cardiomyopathies. It causes a restrictive pattern. It's essentially a base of a bunch of misfolded amyloid proteins that get deposited in the cardiac tissue. They do usually present with a lot of non-cardiac involvement as well. And so the amyloid protein can deposit itself not just in the myocardium, but really any organ. So it can cause a number of different extracardiac manifestations. So these people, from a cardiac perspective, usually have HFpEF. It's associated with aortic stenosis. So someone who is young, a 50-year-old or 40-year-old woman coming in with AS and a thick LV, should get worked up for amyloid because it's unusual to have in a tri-leaflet aortic valve to have aortic stenosis. And then you want to look at other cardiac manifestations. I highlighted carpal tunnel syndrome because this is often, it's kind of like a testing favorite, is that, that on their history, they'll say this patient has bilateral carpal tunnel syndrome. And it's just important to like make sure that flags in your brain that this could be an amyloid. Because you can see that the extracardiac symptoms are often very kind of like non-specific, wouldn't really trigger you to think that there's some associated underlying cardiac issue. But certainly these are very classic features of amyloid, and so you should recognize them if you see them on like someone's past medical history. Um, we're recognizing it more, which is useful because there's really high mortality rates associated with amyloid. Amyloid is classified into two subtypes that are treated quite differently. And so we're going to start your workup, as you know, with your sort of SPEP, UPEP, serum-free light chains. And the reason you're doing that is because you're trying to distinguish, is this an AL type amyloid or is this an ATTR amyloid? So those are two subtypes. If it is in the AL category, nothing cardiology can do for them. They need to go see hemonc essentially and get treated with chemotherapy. First, they need a definitive diagnosis and then they get treated with chemotherapy. The ATTR category of patients, we have medications that we can offer them. So prognosis in ATTR is much better than AL. AL confers a fairly poor prognosis, and they are usually quite symptomatic. The CCS has a amyloid clinical practice update that just came out like a few years ago. And so these pictures are from there. That this is just telling you when you should start suspecting amyloid. These are the sort of cardiac manifestations you would get. So aortic stenosis is often low flow, low gradient. You'll have ventricular arrhythmias, conduction system disturbance, and AFib. And then you have HFpEF associated with it. And then this is just the table from the CCS guidelines about like the workup that you would do. So I don't think you need to memorize this. Just like learn some keywords related to this, right? So you need to do your like SPEP, QPEP, serum-free light chains, right? You're doing your plasma cell dyscrasia workup. And then you're going to do a pyrophosphate scan. So I think that's pretty easy to remember is like pyrophosphate if we're going down the ATTR road, if your AL workup is negative. And then in biopsy, I do believe that this is kind of one of those exam favorites of just being able to know that if you are seeing the words sort of Congo red stain, apple green birefringence, they're trying to tell you that this biopsy is showing you amyloid. And so you don't need to know this in detail, but I would just remember like this is just like a word association. This is amyloid on biopsy. It can't be anything else. Management of amyloid is similar to management of our HFpEFs. However, these patients are very, very volume sensitive. And so very infrequently do they tolerate beta blockers. They often, these patients are never going to get on an ARNI. You can try to get them on an ACE or an ARB if they'll tolerate, but they're often very hypotensive. They're orthostatic. They don't tolerate beta blockers, calcium channel blockers, really any of those medications. So often you're kind of left with trying to diurese them. You can add a, SGLT2, MRA. You do want to anticoagulate if they have atrial fibrillation, regardless of their CHAD score. And pacemakers, defibrillators, and transplant only if in very selective patients. But I think the rest of this is kind of out of the scope in terms of the advanced therapies. Inotersen and patisiran are things that are used for hereditary type. You will potentially see the words tafamidis. So tafamidis is used for any type of ATTR cardiomyopathy. It's probably our most commonly used amyloid medication. And again, I would just make the word association tafamidis, amyloid, ATTR amyloid, and that's one of our treatment options. Next, we're gonna talk like very briefly about I think this is the only slide on cardio onc. The biggest thing to remember is that someone presents with heart failure, we're asking of them about, chemotherapy, if they've ever had exposure to chemotherapy. And then these are kind of like the most commonly brought up chemotherapy agents. There's like basically every chemotherapy agent has some sort of cardiac toxicity, but these are the common ones that are brought up. So the anthracyclines, so like doxorubicin and that category of medications cause systolic dysfunction of your LV, and that is irreversible dose-dependent systolic dysfunction. So that's very bad. Um, Trastuzumab, the HER2 inhibitors, they can also cause LV dysfunction, but remember that those are reversible. So if someone is on a HER2 inhibitor, they develop systolic dysfunction because these people are getting serial echocardiograms to continue monitoring for their EF, and they have a reduced EF. Usually they will either reduce the dose or change the medication, and you should see their LV function return to normal. The other association in terms of chemotherapies is ibrutinib being very arrhythmogenic, causing AFib often. And so I remember that's kind of an association that's useful to know. You don't need to memorize all these kind of other ones. But this last one, immune checkpoint inhibitor, I think it's worth just highlighting here because these are being used more commonly in the oncology world. And they're very effective from a cancer treatment perspective. They are related to immune checkpoint inhibitor myocarditis, which confers an extremely high mortality. And so these patients um, basically have over a 50 to 60 mortality rate if they do not start treatment within the first 24 hours of presentation. So it's a patient population you don't want to miss. Someone comes in fulminant heart failure and they're on a checkpoint inhibitor. You want to get cardiology involved right away, and the treatment for them that you use up front, and it's possible that this shows up on yours, your exam, is just like pulse dose steroids. So you just want to pulse steroids. I don't think you need to know doses or types of medication, but just a red flag of someone's on a checkpoint inhibitor, heart failure, you need to pulse them. Takotsubo cardiomyopathy, also known as stress cardiomyopathy, something you see quite commonly. It's one of the reversible causes of LV systolic dysfunction that should return to normal in the absence of any other ongoing triggers. It's usually in the context of emotional or physical stress. However, that's not always the case. You do often see it after like a big surgery. Someone had like an ortho surgery and then they've developed and mild to moderately elevated troponins. They usually don't get STEMI level troponin. And this is a very classic ECG for Takotsubo or stress cardiomyopathy. You see something like this, you can't definitively diagnose stress cardiomyopathy. Like this tells you, okay, I think it may be stress, but usually if someone has an ECG like this that's fairly ischemic looking and they have an elevated trope and they're in heart failure, you have to send them for an angiogram. So it is a diagnosis of exclusion. Once you have excluded coronary artery disease or any other clear trigger, that's when you then diagnose them as stress cardiomyopathy. And really, you can't know it was stress cardiomyopathy until you've seen that EF recover after, however, usually 3 months. Sometimes it can be as early as 3 weeks, but you do want to see sort of full recovery of your LV. The typical pattern, so if you see, if it's written on an echocardiogram or an angiogram that they had apical ballooning, that is quite typical for a stress cardiomyopathy pattern. I'm going to glaze over this a little bit. This was from like the prior year's slides where this was kind of a more exciting topic. Basically, the bottom line is that yes, COVID vaccines can cause myocarditis. It's quite infrequent. It's usually in young males, and it's usually when they're getting their second COVID vaccine dose. It's usually not at the first time. And so basically, if someone's had myocarditis with a COVID vaccine in the past, you probably should not give them another COVID vaccine. But that's all I will say about that. And then we're going to move on to valvular heart disease. Any questions before I move on? Let's check the chat. No. Okay. We will carry on. So I think, all of this is kind of listed in the high yield topics. To be honest, I think aortic stenosis is the most useful one for your cohort to know in internal medicine, because as you know, it's like the most common valvular disease we see. It's the most commonly tested one. I would know AS well. I would know everything else less well, probably. These are the guidelines you can refer to. This is a massive guideline, the AHA guideline. I would use it only as a reference if you needed clarification about something. Please don't read it in full. The principle to sort of remember is that valvular disease cannot be treated by medications. They can be, temporized. You can give people medications to feel symptomatically better. If they have a bunch of pulmonary edema, you can decongest them. But ultimately, these patients need valve intervention, whether that's surgical or percutaneous. And so that's one thing to remember. And then I would, in terms of like what I would focus on, is physical exam findings for these valve diseases, and then when to refer them. And I'd really only know the class 1 indications. I would not know, like, I don't think it's worth you learning all the subsequent indications. So class 1 indications and physical exam findings. Aortic stenosis, everyone is probably quite familiar with this, but the etiology is most common, is age-related degeneration of your aortic valve. Then there's your bicuspid valves that are a congenital abnormality. That's basically just fusion of two of your cusps. You can have a unicuspid valve as well, but this is sort of 1 to 2% of the population has a bicuspid valve, also associated with aortic aneurysms. So just useful to remember that you need to look at if someone is like diagnosed with a bicuspid valve, just take a look at the aorta to make sure that there's no dilatation there. And then rheumatic valve disease in North America is very uncommon. Usually rheumatic disease will affect your mitral valve first, and then you will see aortic involvement as well. But certainly people can have rheumatic disease of your aortic valve. This is the most famous sort of graphic when it comes to a natural history curve in medicine, and that's of aortic stenosis, and how this is really just to impress upon you how poor the prognosis is once you have onset of symptoms. And so you have this like long latent period, and then they develop symptoms, and you can see their prognosis is kind of less than, usually we say 2 years after the onset of symptoms. So this is certainly when you want to think about urgent intervention. Your typical classic symptoms of aortic stenosis, as you know, are that of angina, syncope, and heart failure. Once you get to the point where you have heart failure because of your aortic stenosis, you have a very poor prognosis. It says 2 years, but I think we'd probably estimate that it's less than that. We kind of talked about these first two columns. In terms of your physical exam, I think you get tested about this clinically on the wards all the time as well. And so I think everyone has probably memorized this, but usually you'd have a pulsus parvus and tardus, and that's just because you have such a outflow obstruction to your LV that you have a very slow peaking upstroke out of your aorta, and that is manifested in all your peripheral vasculature. If you have severe AS, you're going to have a soft or absent S2. So as your aortic stenosis becomes more severe, your S2 is going to get softer, and it's going to start peaking later. Your murmur will start peaking later, the more severe you are. Okay. And then If you don't have radiation to your carotid artery, then it should say it helps you rule out severe AS. You could still have AS without radiation to your carotid, but it helps you rule out severe AS. Okay. In terms of the valve numbers, in terms of cutoffs, I don't think you need to memorize any of your valve numbers outside of severe AS. I wouldn't worry about the other valves, and I wouldn't worry about your mild to moderate categories. I think this is a very sort of easy road to memorize if you don't already know it. It's basically when you look on echo, you want your max velocity to be greater than 4, your mean gradient greater than 40, and your valve area less than 1. Okay. And so it's 4, 40, and 1. I think if you remember that, I think you're good in terms of aortic stenosis cutoffs. If you have some discrepancies, then you can do a cardiac CT. You can look at your calcium scores. There are specific cutoffs that we have for severe AS for men and women. For men, it's 2000. For women, it's 1200. You don't need to know that, but it is useful to know that a cardiac CT can help you determine if someone has severe AS. Class 1 indications for valves. So, I mean, they use a lot of words to sort of tell you when you're definitely going to refer someone for a valve, but I think I kind of remember it in 3 points. So, anyone with symptoms, you're referring them for intervention. Okay. So, I don't care if it's low flow gradient or whatever. If they have symptoms, you're going to refer them for intervention. If they're severe, okay, so if your echo tells, your echo shows that the gradients are severe, your valve area is less than 1, your gradient's greater than 40, but they're asymptomatic, then you look at your LV function. So for all the valves, you're going to notice that they have an LV function cutoff for severe asymptomatic people, because it tells you that while they don't have symptoms, there is clear remodeling of their heart. And some of that's going to be irreversible. So we want to intervene on this valve before this person goes into fulminant heart failure, or their EF is, so their LV remodels to a point where we can't save it, essentially. And so if you're severe, you're asymptomatic, but your LV is less than 50, you should get referred. And then the easy one to remember for all of your valves for class 1 indications, it's like an easy one to say, is if they're going for another cardiac surgery. So if they're going for CABG or whatever, a myectomy, whatever other surgery they may be going for, and they have severe AS, if they're not symptomatic, you should still intervene on them, because most likely you're going to need to intervene on it within the next 2 years anyways. I would not commit to memory the 2A indications necessarily, but just know, like, if you see a velocity greater than 5 or like severely high gradients, you should refer that person even if they're asymptomatic. Low flow, low gradient aortic stenosis is often a point of confusion for people. And I remember it was for myself when I was studying for this. The first step is to essentially look, it's a fairly like simple concept when you think about it. And so this is like high gradient severe AS is like our normal AS, okay? It meets all those echo criteria I told you about. So it's high gradient, meaning your gradient's greater than 40. So it's severe. This is like the clearest situation, and you're going to send them for a valve intervention. There's like many different tables out there that tell you how to work through your aortic stenosis, but I think this is helpful. You have low gradient aortic stenosis here, meaning the two pieces that they're looking at saying are discrepant are your aortic valve area and your mean gradient. So when we start our sort of pathway for low flow, low gradient, we're dealing with patients that have an aortic valve area less than 1. So they're severe in terms of their valve area, but their gradient is discrepant. So their gradient isn't greater than 40 yet. And so then you're left with the question, okay, is this severe? Is this not? The next thing you should look at is your ejection fraction, because you want to know, is this person's gradient low just because they're not generating enough pressure to create that gradient because they have an impaired EF? Okay, so that's the most common reason why someone would have discrepant valve area and a gradient. You look at their EF. If it's low, so if it's less than 50, that's your classic, this is like simple, right? You're like, okay, my EF's low. Clearly, I'm not generating enough pressure. This is probably my classical low flow, low gradient AS. Okay. If your EF is greater than 50, then you want to look at your flow. So you're really looking at your stroke volume. You're looking at your stroke volume index, which is what these numbers are. And if it's less than 35, then you have something called paradoxical low flow, low gradient AS. If it's greater than 35, then you have normal flow, low gradient AS. Okay. Um, you can spend a lot of time trying to understand this. I will say I don't think it ends up being very important to know the details of all of this. What is useful to know is if you are in this category of low flow, low gradient, you have to know what your next test would be. And so it's always okay to say, I'm going to do a dobutamine stress echo. And so what the dobutamine stress echo does is it helps you figure out if you're dealing with pseudo-severe AS or true severe AS. And so what you're doing with the dobutamine stress is you're essentially improving any impairment to your stroke, to your actual stroke volume. You're increasing your stroke volume by at least 20%. And if you do that and you're overcoming the issues of having a reduced EF, and you've now increased your gradient to greater than 40 and your valve area remains less than 1, that gives you the answer that this is truly severe AS. If that doesn't happen, then it's pseudo-severe AS, in that your gradient does not increase when you increase your stroke volume. So this is not severe AS. This person does not have severe AS. They probably have just a small aortic valve area for whatever reason. Maybe they're a little lady and they just don't have a very large aortic valve. And that's okay because remember, these numbers are not indexed. And so these people are not like severe AS, they don't need intervention. So the people that need intervention are your true severe AS or your low flow, low gradients, like classical low flow, low gradient, or your paradoxical low flow, low gradients. Okay. So as I was saying, the two things to remember, so like spend some time trying to understand that, but I wouldn't like go crazy trying to know all that entire pathway. The important things to remember is dobutamine stress echo is going to give you some additional information because it's going to increase your stroke volume. And then, as I said, you're going to get, if you're still not sure what kind of AS you have, you can get a cardiac CT with a calcium score that will classify your aortic valve as severe or not severe. So those are your two sort of follow-up tests you do if you have discrepant numbers. Okay, I'm going to skip over that. This is from the AHA guidelines. Next thing I'm going to talk about is like aortic valve interventions. I realize I have quite a few slides to get through still, and we only have half an hour. Is everyone alive still? Everyone's doing well? Okay, we'll keep powering through. Thanks, Entry. Okay, so aortic valve interventions, main things for you guys to know is there's two options. You can do a surgical valve replacement or you can do a TAVR. TAVR is usually favored if you're older or if you have high surgical risk. So if you're not going to be a good surgical candidate, you should do a TAVR. If you're a younger person and you can tolerate anticoagulation reasonably well, you should get a surgical valve. Remember, surgical valves can be one of two ways. It can be mechanical or they can be bioprosthetic. Mechanical valves have a very long life. They can basically last forever. So young people should be getting mechanical valves typically. Obviously, it's a discussion with the patient. The problem, sort of the downside with mechanical valves is that they need lifelong warfarin anticoagulation. So if there's super high bleeding risks for that patient, then you want to just be a little bit more thoughtful. Bioprosthetic valves, the benefit of those is that they don't require lifelong anticoagulation. You can usually just keep them on aspirin at most. They get anticoagulated for the first 3 months, but then after that, just aspirin or nothing. TAVR valves are always bioprosthetic valves. you probably wouldn't have to make a decision about one versus the other, but this is just, the TAVRs are reserved for older, higher surgical risk people. But recently, we are using them more in younger patients, mostly because the longevity of these bioprosthetic valves was initially estimated to be around 10 years, but we're seeing that, people are living with them for like 15 years now without any restenosis. So I anticipate that that will change how we use our TAVRs. We'll probably use them more liberally. I think we talked about all of this. That's aortic stenosis. That is the highest yield valve disease that you guys need to know about. I'll talk very quickly through AI because I don't think it shows up very much. Remembering that acute and chronic AI present quite differently. If you have someone presenting with acute aortic insufficiency, you definitely want to rule out things like endocarditis and an aortic dissection. Those are very common causes of acute AI. Chronic AI is a little bit different. You can be sort of primary valve degeneration, or it's secondary to something like aortic root dilatation, or a chronic dissection. You don't need to know the classification of your severity, but the medical therapies you can institute to sort of temporize things is anything that reduces the regurgitant flow back into your LV. And so if you reduce your afterload, right? So if your LV is kind of pushing against the lower pressure, you're hoping that you can get more forward flow. And so you can use afterload reduction. You can use diuretics for symptomatic support. You can use things like nitroprusside to reduce your afterload and reduce your regurgitant volume. These are your JAMA rational clinical exam features for you to look at after. But I do think sometimes it shows up like how to do a Hills test. But I'm sure you guys can and look that up after. But the thing I wanted to talk about here is about your class 1 indications. And so you'll remember that for aortic stenosis, your LV cutoff was 50. For aortic insufficiency, your LV cutoff is 55. And so these are the asymptomatic severe people that you're monitoring their ejection fractions and you say, okay, now this person's ejection fraction is starting to drop. And in aortic regurgitation, we don't tolerate that well because AI actually initially will increase your ejection fraction, increases your stroke volume. Because you have so much backflow, more stuff is getting out of your LV. So if you get to a point where your LV is becoming dilated and dysfunctional, even a little bit, right? 55 feels like a normal EF, but in the context of severe AI, it dropping below 55 confers poor prognosis. And so higher cutoff there. And then I honestly, that's the main thing I would remember. Remember, anyone who's severe, anyone who has symptoms gets referred for surgery if you're asymptomatic severe with your EF cutoffs, and if you're going for another cardiac surgery. So it's like, if you remember those three things, it's the class 1 indications for almost all the valve interventions. Mitral stenosis is sort of the next thing we'll talk about. There's most of the presentation of mitral stenosis is going to be related to rheumatic heart disease. There's also mitral annular calcification that is related to more age-related degeneration. That is a very difficult thing to intervene on. Most of the time when we're intervening on mitral stenosis, it's because it's a rheumatic phenotype. They usually present with heart failure. They have severely dilated left atriums because you have essentially this very tight outflow out of your atrium. That volume stays in your LA and you become dilated. And whenever you have a dilated atrium, you're going to develop heart atrial fibrillation, and you're going to have a dyspnea and quite a bit of pulmonary edema usually. In terms of the physical exam, I kind of highlighted the things I think you should know. So you have this opening snap that happens right at the beginning of diastole, right? So right as your LV is trying to fill, your LA is trying to fill your LV. You have a very stiff mitral valve. It's going to snap open, and then you're going to hear this diastolic murmur throughout diastole. Sometimes you'll have features of pulmonary hypertension as well. And so I just put the features there if they're like word associations you want to make, a loud S2 or a palpable P2. Those are features of pulmonary hypertension. As your MS severity gets worse, your S1 will become softer. Okay. And that's all I'll say about that. If you really want to know the echo cutoffs, it's fairly simple for MS, mean gradient greater than 10 and a valve area less than 1.5. I think the valve area less than 1.5 is easy to remember, but that's your sort of severe cutoff. You want to increase your diastolic filling time, much like you would in HCM, for example. So you're going to use beta blockers. That's really the only medication that helps with MS. And then you're going to refer these people for intervention. So there is a non-surgical intervention you can do for MS called a balloon commissurotomy. And that's essentially when they go in and they expand a balloon into your mitral valve. There are some criteria. You may have heard of the Wilkins score. That there's some criteria that tell us whether someone's going to be a candidate for balloon commissurotomy. It is contraindicated if there's an LA thrombus or if you have MR. And that's all I will say about that. The other thing is these are the people that need anticoagulation with warfarin if they have rheumatic MS related atrial fibrillation. Those are warfarin candidates. They also should get anticoagulated regardless of their CHAD score. They have a very high risk of thromboembolism. MR, usually it's chronic. If it's acute MR, think about ischemia and mechanical complications like we talked about earlier, papillary muscle ruptures and endocarditis. You should think about endocarditis anytime you're given a stem about new valve dysfunction. It's poorly tolerated again because your LA becomes quite dilated and essentially develops, you can easily develop atrial fibrillation as well. And AFib is very poorly tolerated in people with MR and MS. You can have primary MR, which is related to valve sort of degeneration, or you can have secondary functional MR, which is related to dilatation of your atrium, dilatation of your left ventricle. And those are very difficult to fix surgically. Primary MR, that's a valve issue, can be dealt with a valve surgery. But you can imagine if your LV is very dilated, then, changing your mitral valve is not really going to help. You're still going to have an issue with actual closure of your leaflets. And so that's a little bit trickier to manage. This is the situation where we'd use things like a mitral clip. So that's like a percutaneous clip that we can put in the cath lab. Don't need to probably know that. Physical exam, I think that's like kind of the most important things about your valve disease is your physical exam. You're going to have a holosystolic murmur, best heard at the apex. I wouldn't really care to remember the posterior or anterior jets. You may have an S3, and then your murmur is going to get louder with anything that increases your afterload. So whether that's squatting or hand grip, and softer with anything that decreases your afterload. Then yeah, that's it. Indications for intervention, the cutoff for MR is less than 60. And other surgery and severe primary MR, you can see that secondary MR is not in this class 1 indications category. Secondary MR, as I said, very difficult to treat surgically. And so usually how you treat these people is you treat their heart failure. And so you put them on GDMT. You can consider a mitral clip. You can revascularize them if you think there's some component of ischemic MR and you have a very restricted leaflet. But you can see that you have very limited sort of options for secondary MR. Valve replacements wise, anyone with a mechanical valve should get lifelong anticoagulation with warfarin. The INR targets depend on what kind of valve they got, but you do not need to know that. That's out of your scope. You just need to know that you cannot anticoagulate a mechanical valve with DOACs. In terms of bioprosthetic valves, as I said, usually you get lifelong aspirin, but you do not need anticoagulation. Any questions? Next is AFib. I think there's something in the chat here. Actual question. Okay. Okay, so atrial fibrillation. How many slides do I have left? Okay, we're gonna whiz through this. Oh my God, 15 minutes. I think this is a very useful guideline to learn. What I would tell you to do is look at your AFib guidelines in CCS, and then there's these really nice tables about basically flow charts about what you would do for a patient who presents with AF. And if you remember like those two charts, then you're good. And I'll show you what those are. These are classifications of AF. The principle behind this is that if someone is in AF for forever, okay, if they're in AF for like the last 10 years and they have this dilated atrium, there's no point of using a rhythm control strategy. There's no point of cardioverting them. These people are going to live in AF forever. Okay. You can't even like ablate them. If you have, it's these paroxysmal people that, or early in their diagnosis trajectory, where we are thinking now more of considering rhythm control strategies as opposed to just exclusively rate control. Okay, so that's the utility of being able to classify AF into these categories. These are just the concept that there are usually some atrial fibrillation triggers, and then there's some substrate of the myocardium that makes people susceptible to staying in AFib, sometimes forever. And so I think the point I'm trying to get across here is that always assess anyone who has AFib, assess for these risk factors, and see how many of these can be modified. So if someone has someone has obstructive sleep apnea, you have to send them for a sleep study and get them on a CPAP machine. You have to tell them to reduce their alcohol intake. You want them to lose weight because people's AFib can actually go away if you treat these reversible risk factors. You treat their hypertension, their AFib can go away. So that's the point I'm trying to get across here. This is for the oral exam, so I'm going to skip over this for the oral exam. These are the tables I'm talking about from the CCS guidelines. The three sort of pillars of therapy is assessing your thromboembolic risk using your CHAD 65 score, managing your arrhythmia either via a rate or rhythm control strategy, and then assessing your risk factors and determining if there's something modifiable. Okay. This is something for you to look at for the oral exam, all the sort of modifiable features you can use, easy points to get there. CHAD score, I'm sure you guys know this very well, but this is, we don't use CHADS VASC in the guidelines, we use CHAD 65. I just put this in for your reference. I know this is always a difficult thing to remember as your DOACs and creatinine clearance. And so that's there for you to look at. And reversal, this is all in the CCS guideline. I just wanted to move to the main thing about how to manage acute AFib that's presenting to the hospital. And so it's very easy if they're hemodynamically unstable. You don't care how long they've been in AFib, you're going to cardiovert them because they're unstable. If they're stable, that's when things get a little bit more complicated, when you have to think through things. You can either decide on a acute rate control strategy or a rhythm control strategy. There are very few patients who are going to be able to tolerate or who are going to meet criteria for upfront rhythm control strategy. Rhythm control can mean cardioversion electrically or cardioversion chemically, right? So you're either putting them on like amio or something or cardioverting them. So those are both considered rhythm control, right? You're putting them back into sinus. Very few people will meet this criteria, right? So you need to have AFib less than 12 hours with no recent stroke. Okay, so that's not very many people are presenting within that 12-hour window. Or you've had AFib for 12 to 24 hours and you have a very low CHADS risk. So those are people that you want to go ahead and if they meet those criteria, you can go ahead and cardiovert them. Remember, whether that's chemically or electrically, but you do need to keep them on anticoagulation for 4 weeks after. If you're choosing the acute rate control strategy, then you're looking at your ejection fraction. If you have a reduced EF, then your options are going to be things like beta blockers. You want to use those very judiciously and reduce EF. Most commonly, people are going to go to things like amiodarone or digoxin. If their EF is preserved, you can use a beta blocker, calcium channel blocker, or DIG. This is the table that you should know because I do think this is kind of high yield for you guys. So we kind of talked about this group of people where you can where they have a fairly low thromboembolic risk because they've had a low duration, short duration of atrial fibrillation. So you want to start their OAC as soon as possible. And then you're going to leave them on anticoagulation for 4 weeks after. If they don't meet any of these criteria, which is like the majority of people that we see. So if it's valvular of any duration, meaning if it's MS related, or mechanical valve related, or it's really like any other duration of AFib, especially if you have a high CHADS risk, you need to anticoagulate them for 3 weeks before you cardiovert them. Okay. So the numbers to remember are 3 weeks before and 4 weeks after. You anticoagulate 3 weeks before your cardioversion and then 4 weeks after, always. Okay. The only sort of caveat to that is if you have one of these high risk people, but you really want to cardiovert them, say they're in heart failure and you think it's because of the AFib, you need to do a TEE specifically to look at an LA thrombus. So you want to rule out an LA thrombus. You don't see a thrombus there, you can cardiovert them and then keep them anticoagulated. This table is worth spending some time looking at, but it's the idea of in these people with persistent atrial fibrillation, when you're trying to think about if you're going to rate control them or rhythm control them, you want to see if they meet any of these criteria. So if you think they've been diagnosed within the last year, so it's like a short duration, if they're very symptomatic, they've had multiple presentations to hospital, you're having a hard time achieving rate control with a beta blocker, things like that, or they have an arrhythmia-induced cardiomyopathy, like a tachy-mediated cardiomyopathy, then you want to think more of a rhythm control strategy, okay? Otherwise, you can just keep people on rate control and you can try to optimize it. If their symptoms persist, try to put them into sinus with a cardioversion. If not, look into rhythm control. All roads of rhythm control, so whether, paroxysmal, or these persistent AFibs, they all lead to catheter ablation. And I'll show you that in the next slide. If you're just paroxysmal, you can consider doing a pill in the pocket strategy, or you can put them on an antiarrhythmic. Usually not going to be the call that you guys are making. But the point is that in the rhythm control strategy, you do need to just try to remember which medications can be used in which conditions. So amiodarone, this is the easiest one to remember. You have heart failure, EF's low. The only thing you can use is amio. You have no other options. You have heart failure, EF is preserved. You can only add on sotalol to that. Okay, so heart failure basically excludes many of our rhythm control strategies. If you have CAD, you can use amio, dronedarone, and sotalol. And then if you have no heart failure and no CAD, you can use basically everything, including propafenone and flecainide. As I said, all of these roads ultimately lead to catheter ablation. All of these patients on rhythm control strategies should be referred for ablation. This is quite simple in terms of rate control. You guys do this all the time. So that's just for you to look at. Any question? Maybe I'll just power through and then you guys ask me questions at the end. Sorry, I didn't think this would actually be 3 hours long. Okay, VTs, I think very infrequently comes up on your exam. The important things to remember is that sustained VT is anything greater than 30 seconds. or if it's hemodynamically significant. So if someone syncopizes even with a short run of non-sustained VT, it's still considered sustained VT because it caused some hemodynamic consequence. If it's monomorphic, you're thinking scar related. You have to think, could it possibly be ischemic? But almost all of the time, it's related to an old scar from an old infarct or due to some underlying structural heart disease. If it's polymorphic, it's usually one of two things. It's either QT related, leading to torsades, like prolonged QT, or it's in the context of active ischemia. So anytime you have polymorphic VT, you have to really think about if you're going to send this person for an angiogram, and you almost always do, unless you have a compelling reason not to. This is in terms of differentiating VT from SVT. You don't need to know the Brugada algorithm, but it is useful to think about, sorry, one second, where was it? It's useful to think about what the patient population looks like, right? So if you're given an ECG and you're not really sure what it is, if you're told that they have underlying structural heart disease, if they're old, they've had a previous MI, it's almost you have to assume that it's VT if you're unable to tell the difference. But I don't think they're going to ask you, very difficult ECGs to determine if it's SVT or VT. But the patient history is very helpful in determining how suspicious you are. So if they're like a young, healthy person, it's much more likely that it's an SVT. This is from the CCS guidelines on management of VT. I think you know most of this. Beta blockers are very helpful in VT, the most helpful in VT, such as propranolol. We use amio, and then we can use procainamide first line if they're hemodynamically stable as well. And then in terms of polymorphic VT, you want to replace their magnesium, their potassium. You can overdrive pace them, and you can beta block them. Okay. ICDs for secondary prevention is fairly intuitive. So if someone's had a VT or VF arrest, you should obviously put an ICD in them. If you have, and then I said, we were talking about the HCM population. So there's some people with underlying structural heart disease that you would do sort of a risk calculation for. And if they've had a prior syncopal event or any VT that's sustained, but not necessarily leading to a cardiac arrest, you should consider them for ICD. So in your sort of scope, I think it's just important to recognize that, this person needs referral to cardiology or AEP for consideration of ICD. Someone who's had a cardiac arrest should not, related to VT or VF, should not leave the hospital prior to getting a secondary prevention ICD. It's not something that's done as an outpatient down the road. It has to be done at the index hospitalization. Oh my God, can you believe it? I'm not done. Okay, pericardial diseases. If you guys have to drop off the call, I completely understand. I know this has gone very long, so I apologize. Pericardial diseases. Pericarditis, constrictive pericarditis. I'm going to leave that here for your oral scenario. You know how to identify pericarditis. The key things you want to look for is diffuse ST elevations without reciprocal changes. And so if you don't have reciprocal changes that are suggestive, sometimes it's hard to tell if it's ischemic or not, right? It's easy to think that this is an inferior MI. It's multiple territories and there's no reciprocal ST depressions. So that's kind of telling. PR depressions, and then AVR, you have PR elevation, and you can even get, ST segment depression in AVR, okay? The investigations are pretty straightforward that you'd want to know. These are your diagnostic criteria, and so you need to have at least 2 of these 4 to be able to diagnose pericarditis. You want to get an echo on these people. And I think this is probably the highest yield thing to know about pericarditis is determining if this patient needs to get admitted to hospital. So I would commit this to memory in terms of, if someone has a fever, if someone has a large pericardial effusion, if they're post-trauma, or if they have a positive troponin. It's not one of those cases where you can just start them on colchicine and NSAIDs and send them home. Those people need to get admitted for monitoring. They're at higher risk of arrhythmias because they have, this person has involvement of their myocardium as well. Medications wise, NSAID colchicine is your mainstay of therapy. If it's post-MI, you consider using aspirin. Prednisone can be used if there's like a contraindication to NSAIDs. Even then, it's not recommended to be used outside of the situation where it's autoimmune related. So someone's having like a lupus flare and they have pericardial effusion related to that. That's a different story. They can use pred. Otherwise, it actually increases your chance of recurrent pericarditis. So avoid that, and always remember you're putting someone on NSAIDs and colchicine. You should consider putting them on a PPI as well. Okay, the ESC guidelines are very good for pericarditis. Tamponade, these are some like I think fairly straightforward concepts in terms of management and workup. Pulsus paradoxus is the most sensitive finding, and your cutoff for pulsus paradoxus is really anything less than 10 to 12. Usually we use 10 as our cutoff. It's can be seen with other pathologies, including severe COPD or PEs, and even in constriction. You should know how to do a pulsus for your oral exam, so just make sure you read this. And there's a video that we've attached as well. What I'm trying to tell you here is that do not be reassured by a small pericardial effusion. So the pericardium is a very small space. Even with a few cc's that accumulate rapidly, you can have hemodynamic compromise and tamponade. So you can have a very large effusion that was slow growing, that has liters and liters, that is not hemodynamically significant. And you can also have a very small effusion that causes tamponade. It all depends on over how much time that volume accumulates. And so don't be reassured by a small effusion. The principle of constrictive pericarditis is that you basically have a very scarred and non-compliant pericardium that eventually causes, so your RV is a very sort of floppy chamber, and usually it likes to expand outwards when it's filling. When you have pericarditis, it's not able to sort of accommodate that fluid. And so you have what we see as intraventricular dependence. That's kind of like the core tenet of all the findings, physical exam findings of constrictive pericarditis, is that your RV is filling. It can't expand outwardly towards the pericardium because it's stuck. And so it moves and pushes the septum towards the LV. And so now you have your RV pushing on your LV when it's filling. And your LV subsequently has reduced output. And so these people usually have kind of a low output state. And the features that you're seeing on their echo and even with their GVP with Kusamal sign and those features of constrictive pericarditis, that's all really related to the concept of ventricular interdependence. Okay. I would read through this sort of what they present with is right heart failure and impaired diastolic dysfunction. And you want to echo them, you want to CT them, CT or MRI, and ultimately you usually need a right heart cath to do invasive hemodynamics to definitively diagnose constrictive pericarditis. Mainstay of management is surgery. It's a pericardectomy, which is very high risk. So only people that are good surgical candidates can go for that type of procedure. I put this, I don't think you need to memorize all the features of this, but I would memorize this first section, okay, with these sort of clinical features. This tends to show up about the distinguishing tamponade, constriction, and restrictive. You don't need to know this last column is talking about RV infarcts. Ignore that, but this sort of top section worth memorizing. Okay. I swear I'm almost done. Dyslipidemia. I'm not going to get into too much detail about this because I think this is fairly well understood by most people. This is the CCS dyslipidemia guidelines. This is how we screen people. The main thing I wanted to say is remember, like now we're using ApoB and lipoprotein A's as well as risk modifiers. So those can be checked in individuals where you want to determine if they would benefit from a statin. These are our statin indicated conditions. You guys are going to memorize this fully well by the end of your studying period. Statin indicated conditions And then this is when you'd use statins for primary prevention. Um, so these are your sort of LDL cutoffs. And this is where Framingham risk score is helpful to help you know which risk category you fall into. Um, Excellent. PCSK9 inhibitors, I don't think you need to know much about it. Just know that they exist and that if someone is not meeting their lipid targets, that you should refer them for consideration of a PCSK9. There are some questions I know about the management of statin-induced myopathy. There's kind of a spectrum of different issues you can have with statins. The main thing you want to do is you want to look for drug-drug interactions with a statin or other contributing drugs that are causing myopathies. You want to change the statin type. You can reduce the dose and then you want to re-uptitrate slowly. So usually you don't want to start at the same dose, like the equivalent dose as the statin you just stopped. Pravastatin tends to be the best tolerated medication, also the only statin that's safe in pregnancy. So you can always switch them to pravastatin. But you don't, as per the guidelines, don't really need to do routine CK monitoring, only if you suspect that they have some form of sort of like true myopathy or myonecrosis. Do you need to check their CK levels? Hypertension is covered in the nephrology lecture, so I will not go into that in great detail. Hypertensive emergency for the oral exam, we have our slides here, so take a look at that. Diabetes is covered in the endocrinology lecture. And then there's some slides that I've left in here about the thoracic aorta disease. I think it's fairly low yield. The main things I wanted to highlight is that a type A dissection requires urgent surgery. A type B dissection typically does not require urgent surgery unless it's involving these distal arteries and causing end organ damage, right? So if it's involving your renal artery and you have, a progressive AKI and you think you have poor perfusion to your kidneys, that's when you want to get the surgeons involved and say, do we actually need to intervene on this? Otherwise, it's for medical management. We medically manage with aggressive afterload reduction to try to reduce the wall stress on a dissected aorta. We use labetalol esmolol as our first line, and you can use nitroprusside as well. And so that's basically summarized here. These are your JAMA findings. That's just summarized in one page. And then the only number I'd remember that I think is important for you to remember is just your run-of-the-mill aortic root enlargement. 5.5 is your cutoff. So when someone's aorta is getting greater than 5.5, then you want to refer them for surgery. There's a number of other aortopathies with different cutoffs, but I think that is far out of your scope. So 5.5 is when you want to send someone for surgery. In terms of abdominal aortic aneurysms, you're screening men that are greater than 65 who have ever smoked. It's grade 2 recommendation for females, but you do want to screen people who have risk factors. So if they have like a family history of an aortic dissection, then those people are ones you're going to screen. And that's all I'll say about that. Syncope, very briefly, you just want to know who is low risk and who needs like a further workup and things like an echo. There are risk calculators. I don't think they will ask you this in detail, but it's useful to know what features go into determining if someone's syncope is considered high risk. The bottom line is that if someone's ECG and telemetry are completely normal, then it's unlikely to be cardiac. That's not to say it's not cardiac ever, but it is unlikely to be cardiac. And so that's what these scores are trying to identify. Is this cardiac syncope or is it syncope that is related to some other reason? If your sort of workup is otherwise negative and your troponins are normal, then there's probably a low risk category that person can probably get discharged. But you can take a look at the CCS syncope guidelines to just review that. But I don't believe you'll need to know this in detail. In terms of therapies, useful to know is that you can use, first you want to talk about sort of non-pharmacologic therapies. lifting your legs, adding salt to your diet, compression stockings, counter pulsation maneuvers. Those are things we know that help with syncope. But pharmacologically, if they are hypotensive, you can add fludrocortisone or midodrine. If they're hypertensive, sometimes in sort of like the older population, you can add things like a beta blocker, but you want to do so making sure that they don't have conduction disease. And that's all I'll say about that. This is just going over, I just put these guidelines in again for the drive and fly around syncope. So you can take a look at that. And now I promise I'm actually done. I just put the POTS guideline if you want to look at it. POTS is like, I'll say it didn't show up on my exam because it wasn't really much of an entity back then. But if it does show up, I think it's worth looking at. There are tables that essentially say you can, outside of some non-pharm therapies, there's things like ivabradine you can use. So midodrine and ivabradine. So I would just look at the medications to know what your options are. But I don't think you'd be expected to be sort of experts in POTS management at this point. And I just put this table at the end for you guys to look at, which just has some sort of high yield valve disease with what their classic murmurs would be and where how maneuvers would modify these murmurs. I promise I'm actually done now. Thank you for listening. I'm sorry that was so long. I really didn't think it was going to go for the full 3 hours, but um, you guys are welcome. Yeah, the antiplatelet guidelines uh, are extensive, but I think like you have to remember that you're going to be asked this as an internist, not as a cardiologist, meaning you need to make sure that you don't get stuck into the weeds of determining is someone high angiographic risk and blah blah blah. Like just know your standards, right? Like you have an ACS, you're leaving them on DAP for 1 year, you're going to be using Tyceg and prasugrel. You're not going to be using clopidogrel unless you have some other reason. Like that's all I'd know. And so I wouldn't get too stuck in the details because they can be quite overwhelming. If you guys have any questions moving forward, feel free to email me. I think most of you guys have my number, if not my email. It's in the slides as well. But I'm happy to answer any other Royal College questions, but I'm sure you guys are all exhausted, so feel free to go sleep now. All right. Thanks for listening, guys. Thanks for your messages. Nice to see you all. I'll see you later.